Good morning, everyone. Morning, everyone at home. Can someone just respond so I know you can hear me?
Yes, we can.
Fantastic. Okay, we're going to pick up with paper 3 from question 19. So we have a block of questions about diabetes, and we're going to pick up from there. So just let me get myself organised. Karen, is everyone up from downstairs? Okay, right, so question 19. 22-year-old man, weakness and thirst. You suspect DKA. His capillary glucose reads high and a venous blood gas shows a pH of 7.22. What's now required for a diagnosis? So in other words, what are the diagnostic criteria for DKA? Yeah, anyone at home? Yeah, you've got to have the ketones, which either has to be greater than 3 on the blood or 2 pluses on a urine dipstick. Which, just by the by, oh no, okay, I'll leave that for a bit later. Let's just have a quick look. This is the management of diabetic ketoacidosis in adults. We're also going to be looking at it. A short delay while we get the screen. We'd forgotten to turn the projector on. We all need coffee in the morning. Karen, is that fully on?
Yeah, just take some moments
to brighten up. Okay. So this is the adult ketoacidosis guideline, which comes from Diabetes UK. The pediatric one comes from another source, the British Society for Pediatric Endocrinology and Diabetes. But this is the adult one. And if you go on their website, you get everything in a sort of one-page, I know you can't see that, but in a one-page summary of adult DKA management, taking it in blocks of time, you know, first 5 minutes, next sort of hour and so on. But I just want to focus on 2 things from this, actually. Most of it we don't need to worry about. Most of it is for after they've left the ED. But first of all, diagnosis. Now, you can be clever and use the letters DKA to remember the diagnostic criteria. So D, you have to have diabetes or a sugar over 11. K, you have to have ketones. And A, you have to have acidosis with a low bicarbonate or a pH less than 7.3. So it's just a sort of neat way of remembering it, the diagnostic criteria for adult DKA. Interestingly, the glucose doesn't appear in the pediatric DKA diagnostic criteria. It's only in adults that you need to have a high sugar. And we'll come to why that is when we come to children. Okay, and then the next thing is just about, well, what do you do first? And in adults, you start normal saline, and you shortly off at around about the same time you start insulin. Of course, with children, you delay the insulin by 1 to 2 hours after starting the fluids, and we'll come to the details in the children, and we'll go over that a bit more carefully. Okay, 0.1 units per kilogram per hour. And we know that most adults are going to be something like 6 liters water deficient, very sodium deficient, very potassium deficient. And we're going to make that up. But we don't have the worries of cerebral edema in adults, which is what complicates DKA management in children. Okay, we'll move on and come back to a bit more diabetes later. Well, a bit more of type 1, a bit of type 2 diabetes. 83-year-old, nursing home, lethargic and uncommunicative. Type 2 diabetes, she's on those medicines. That's her blood pressure, GCS of 11. and she's got a sodium of 160, urea of 10, glucose of 40. Okay, so let's do a quick serum osmolality. Can you estimate her serum osmolality from those figures there? How do you do it? Okay, does everyone agree with that? What you've been offered there? Double the sodium plus the urea plus the glucose. All right, so sodium, double that, 320. Add the urea, 330. Add the glucose, 370 milliosmoles per kilogram. What's your serum osmolality about? What's normal? 275 to 295, yeah, about 280-ish, and just under 300, which is why normal saline, for example, yeah, is 300, 150 sodium, 150 chloride, makes it 300, which is pretty close to human serum, isn't it? 285, and that's usually for most IV fluids, with the exception of 8.4% bicarbonate, which is 2,000 milliosmoles per kilogram. But with that exception, nearly all IV fluids are aiming for something like 300, aren't they? Because that matches human. But this person has got a serum osmolality of 370, did we say? That is very high, isn't it? That's associated. That means she's very, very dehydrated and concentrated. And the diagnosis, therefore, is HHS, yeah. Let me just touch on a little bit of physiology of diabetes for a moment. Diabetes is really, if you think about the complications of diabetes, two separate problems. It's to do with osmotic diuresis and it's to do with acidosis. And they both are separate. And they both, you can have a range, the mix can vary. So for example, when you have diabetes and DKA, your sugar rises. And once you exceed the reabsorption threshold of the kidney, people know about that, the kidney can reabsorb up to about 10 millimoles. Above that, it goes out in the urine, which is why the urine then becomes positive for sugar. And the higher the sugar, the more pours out in the urine, and it takes water with it, doesn't it? Because it's very osmotic. So osmotic diuresis is a big part of DKA, and it dries you out, and a big part of HHS, but it doesn't make you acidotic. Acidosis comes from the breakdown of fat. So when you normally, insulin stops you from breaking down fat, you lay it down instead. But if you haven't got insulin, you break down fat, you produce free fatty acids, and those are converted in your liver into ketones. And the ketones are acidotic. And that's where the acidosis comes from. So you have these two things, and you can have a mix. And one of the issues with children is you may not have much of this. The sugar may not be very high, but you may have lots of ketones, and you may be lots of acidosis, but not so much of a high sugar, which is why you don't need a high sugar to be DKA in children. HHS, they still have a little bit of insulin, and so they don't really get this. They don't get the lipolysis problem. They just get the diuresis problem. And because they don't get ill in a sense so quickly, because they don't have the acidosis, this goes on longer. And they just get drier and drier and drier. And they're one of the most dehydrated patient groups you ever see. They can get to 20% dehydrated. HHS, that's the thing. They're just dried out from sugar loss in the urine. Does that come across? Does that make sense? So that's what HHS is. They're incredibly dry. So what's the initial management priority? So your question here is not the diagnosis, which you've all got, I think, but what are you trying to do when you treat somebody with HHS? So yeah, it's about being really, really careful. So the priorities in HHS management are about correcting that massive dehydration, but doing it carefully. Because if you move fluid across membranes too fast, you can get odd effects from dilution. You can get this problem in the brain called cerebral pontine myelinolysis. Yeah, you can get these problems from massive osmotic shifts, cerebral edema and things like that. So it's about care. It's about doing it carefully and steadily and progressively, isn't it? It's not about the insulin control. They hardly need any insulin. It's about careful fluids. And what are the other two problems? A couple of other problems they get. Yeah, they're very, very prone. They nearly always get thromboses. So you have to manage that. And because they're also, you reduce consciousness, they get bed sores and stuff like that. That's the other big issue, but doesn't affect us in ED so much. Okay, so that's just a little bit on HHS. Here's the guideline again from Diabetes UK. There isn't a precise definition of HHS, but usually osmolality above 320. Well, our patient was 370. Usually very high sugar. And this is about the goals of treatment. So calculate osmolality, we've done that, and we've talked about, and don't forget we use normal saline. You might think, well, if the patient's 370 and the target is 270, let's give some fluid that's 170 and sort of even it out. But we don't do that. We give normal saline and we allow this gradual correction. And we don't, as it says here, we basically don't do anything too fast. Okay, 21, 16-year-old girl brought in with weakness and lethargy. Her mum says that she's a picky eater and she's really quite anemic. And you've got those numbers there. So MCV's, HB's abnormal, MCV, white cell counts, platelets, INR, calcium. It's all a bit abnormal. What of those would fit best? Yes, B12 deficiency will give you the macrocytosis, the anemia, the low white cell count, and the platelets. These must be explained by something else. Yeah, perhaps she has low vitamin D levels as well. Perhaps she has low vitamin K levels as well. So there's another explanation for those.
Just a quick one. I kind of forgot what normal MCD was. Do you have an example? Give us
They will give you, they used to give you a little booklet when you went in, but now I believe it's on the screen. You've got access to a little folder of normal values. You won't have a problem over that. And apologies, we've given you sometimes, but not others. But MCV, I think MCV goes up to about 96, does it normally? Something like that. Okay. Everyone comfortable about that? We'll come a little bit more to macrocytosis as against the two causes of megaloblastic anemia. That means that not only are they big circulating cells, there's also big cells in your bone marrow. But macrocytosis is just big circulating cells, and there are a series of causes of that. But your bone marrow, it would be normal. Okay, 22, quite quick, an easy one, I think. Just a blood gas interpretation. Everyone happy with this? Acidotic, you do the pH first. Then you look at the CO2 and the bicarb. So you can see that it's a respiratory acidosis, but it's partially compensated and respiratory failure. So it's type 2 respiratory failure and compensated. So there we are. Yeah, D, everyone happy with that one? Very easy one. So, okay. 43-year-old man with a head injury at 2 a.m. You're considering the need for an urgent imaging overnight. Which of the following would indicate that he needs a CT head within 8 hours rather than within 1 hour? It is, yes. I'm going to go through this. So I'm going to go through this in detail and go over why that's the case. Okay, so here's like a one-page summary of the CT head injury guidance, and I'm just going to go through some bits of this. So just like we talked about pediatrics yesterday, pediatric head injuries, you have the first list, and it's the same with adults, the first list. Are any of the following risk factors present? And I'm sure you all know these. GCS less than 13 on arrival. GCS still abnormal 2 hours after arrival. Depressed skull fractures, seizures, neurological abnormalities, base of skull fractures, more than one episode of vomiting since the head injury. Everyone happy with those? Everyone, those are all familiar. Okay, moving on, we go on to what if you don't have one of those? What are the other rules? Well, the next thing that this flow diagram says is, well, is the patient on anticoagulants? Because if they are, they should just have a CT, but it's not urgent. So if you're on anticoagulants, you can have it in the morning. If you haven't got one of that first list, if you haven't got a depressed conscious level, you're fine, but you've had a head injury and you're on anticoagulants, you've got to have one within 8 hours. Yeah, that's okay. What about if you're not? Then there's another list. So if you're on this side, you're not on anticoagulants and you haven't reached any of the first list, you then ask the question, well, did you have any loss of consciousness or amnesia? And if you did, you get to this second list here, which relates to the question. If you've had amnesia or loss of consciousness and you're over 65, you've got a history of bleeding or clotting disorder, it was a dangerous mechanism, and it lists what that means there, and you've had a long period of retrograde amnesia, those are also indications for this 8-hour CT. Okay, this will be on the recording and you will be able to go over that because it is a bit of a complex flow diagram. You've got the first list, the familiar list. If none of those apply, are you on anticoagulants? If so, 8 hours. If not, have you got any of that second list there? Age over 65, dangerous mechanism of injury, clotting disorder, etc. If so, also CT in the morning, 8 hours CT. Is that okay? Any questions on that? It's a bit of a complex diagram. Okay, changing tack a bit. 54-year-old, one-day history of upper abdo pain. Which of the following would suggest pancreatitis as a likely cause? Yeah, absolutely. Rebound tenderness is very much a suggestion of peritonitis, isn't it? Which isn't a primary feature of pancreatitis. Gallstones and alcohol account for the vast bulk of pancreatitis, don't they? And we used to have, in the old days, lots of idiopathic ones, unknown cause. But we've realized over time that a lot of them are caused by very small gallstones, within the pancreatic duct. Okay, what have we got here? 42-year-old man arrives in ED, severe chest pain. He admits to taking cocaine 2 hours earlier, and that's his ECG. And you look at the ECG for ischemic features, and you notice that he's got some T wave inversion across his chest leads, one an AVL. And these are his observations. He's got a fast heart rate, very high blood pressure for a 42-year-old. Most appropriate treatment. I think there's room for discussion over this. It's been practiced to give IV diazepam, and that comes from a recommendation from the American Heart Association in 2008, and they published a recommendation that that's done because it's just helps to calm the patient down and helps to reduce the work on the heart, and that works well. So IV diazepam has been the general thinking, but there's some recent evidence that nitrates work just as well. So I think nitrates would also be okay as an answer for that question, and we need to look at it again. Basically, I thought it was just diazepam, but then somebody challenged it, and I thought, well, actually, when you look at it. There is room there there's wriggle room. Okay.
With nitrates, it would not cause peripheral vasodilation, and all the central blood flow would go to the peripheries, and which might be at risk of achieving.
Like all of these things, empirical evidence wins. So there's studies that show that it works just as well. But what is it said you should not use in cocaine-associated chest pain? Beta blockers, why not? Because the cocaine then won't work on the beta receptors, but it will still work on your alpha receptors, and you'll get massive alpha receptor agonist effect from your cocaine, gut and skin, and it pushes up your blood pressure. Okay, and that increases the myocardial oxygen demand. Yeah, does that make sense? So that's why, again, it's now being questioned, but that's been the received wisdom for a number of years now. One of the ways to thinking about cocaine-related chest pain is because there's been a debate as to why is there so much cocaine chest pain? It's even bigger in the US than here. I think 500,000 cases a year in the US of cocaine chest pain. I don't know if we see that sort of level. They see lots of it. And it's said to accelerate atherosclerosis and increase myocardial demand and cause coronary spasms. It's a mixture of things which causes this. Okay. Okay, asthma. 6-year-old boy, wheeze, difficulty breathing. History of asthma, bilateral wheeze, some slight subcostal recession, talking in complete sentences. Why do we mention that? What's the significance of that? Talking in complete sentences when it comes to severity. That's a marker of severe, isn't it? If you can't talk in a complete sentence. We can't, in young children less than about 8-ish, you can't do peak flows. Yeah, so you have to go by more, by other evidence like talking, like pulse rates, respiratory rate, saturation. Okay, so he's not severe is basically what that tells you, that he's talking in a full sentence. Single best initial therapy. Okay, the majority here going for A, yeah. So where does that come from? Well, it comes from this is the BTS guideline for asthma in children over 1 year of age. And just to say a little bit about severity assessment. So severe, can't complete a sentence in one breath. So it's based on saturation, peak flow, if you can do it, patient can do it, heart rate and respiratory rate. But life-threatening is, it's really, you can tell it by looking at the child, an exhausted child, or reduced consciousness, or low blood pressure, or cyanotic. That's the life-threatening category. We also go by blood gases as well, if you have blood gases. So that's the severity categorization for children over 1 year. And then when it comes to initial treatment, this is the initial treatment. Inhaled beta-2 agonists, our first-line treatment. Metered-dose inhaler, that's what that stands for, an inhaler and spacer is the preferred option, mild to moderate asthma. More severe, nebulizer. But for the mild to moderate, big spacing device, do 10 puffs into it. If its symptoms are refractory, add ipratropium bromide. Why don't we use ipratropium bromide straight away at first presentation? There's a small percentage of children, of anybody, can get a paradoxical reaction to ipratropium, and they, instead of getting better, they get worse. They get bronchospasm from it. It's a very small percentage, but you can then end up chasing your tail. This patient's getting worse and worse, treating them harder and harder. You see what I mean? So you just use salbutamol first. Same for adults. We should use salbutamol only first. And it also mentions that you can add magnesium into the nebulizer, into the pot, yeah, as another option. But only for patients who have got low saturations. Okay, so that's a little bit on pediatric asthma. 64-year-old man unconscious at a bus stop. you think he's had a seizure, but he says, I've never had it before. And here's his blood count. So which of the following is the most likely explanation for this result? Okay, everyone happy with that? Alcoholism is the most likely because it ties together the story and the blood result. But any of those, of course, could give you a macrocytosis, couldn't they? A severe B12 deficiency would give you much more than that. But why would chronic bleeding give you a macrocytosis? Because the reticulocytes are bigger, aren't they? The new cells. The young cells are bigger, and that pushes up the average. But also pregnancy makes you macrocytic, hypothyroidism does, phenytoin does, alcohol does, liver disease does. So those are the things that could come up in a macrocytosis question, because there's a little bit of hematology in the exam. Okay. 28. 74-year-old man, acute shortness of breath. Treated for an ACS 10 days ago, respiratory distress, crepitations, pitting edema. Heart rate 122, blood pressure, respiratory rate 32, SATs on oxygen is not too bad. Single best initial treatment. Yes, frusemide, isn't it? It's nothing clever. It's frusemide is the first treatment. And this comes from this guideline, acute heart failure. And this did have quite an impact when it came out. So not using opiates. We used to give everyone opiates, diamorphine at one time. Give IV diuretics. If they're already on diuretics, give them a bigger dose. Double it is the sort of standard sort of thinking. Don't necessarily catheterize everyone, discuss how they're going to cope with the diuresis. And don't routinely use nitrates. Nitrates can be used, particularly if they've got associated chest pain, but you've got to have enough blood pressure to cope with a bit of nitrates because it'll drop the BP, won't it? So you've got to be careful. Question in the room.
Why can't we use IV nitrates in this one where the blood pressure is good?
It's not that you can't, it just says which is the single best initial treatment.
It is something that's standard that
So the question in the room here is why couldn't nitrates be the first answer? So it's because of the guideline. I'm just quoting the guideline. And it says offer IV diuretic therapy.
To my mind, because IV nitrates are much better control for the blood pressure.
Yeah. We have to just go with the guidelines. Nitrates are there, and they definitely can be used in people with heart failure and chest pain, or people with heart failure and a high blood pressure. But what they're getting at is don't use them routinely because some people you'll crash their blood pressure. And so you've got to be careful with them. Okay, 29. 83-year-old, unwell for a few days, ECG on arrival. Which electrolyte abnormality is most likely with that? Okay, everyone happy with that? Tented, tall T waves. Yeah, it's classic ECG. Okay, 30, 61-year-old man, severe right knee pain and swelling following a karate kick. And this is a true story. Perhaps a bit overambitious. What's the diagnosis? Okay, so you can just about make out the top part of his patella is up there and the bottom part of his patella is there. So basically he's flexed his quadriceps powerfully, and instead of tearing one of the tendons, he's just taken the patella in half. Okay. Okay, now this one, I'm not sure we got quite the best x-ray for this question, but an 84-year-old female brought in after a fall, and this is her left ankle x-ray. I think I'm actually not going to specific about the point that I think we need a better X-ray. What we were trying to show is an X-ray with what's called Taylor shift. You're familiar with the concept of Taylor shift? If the top here of the talus is not well centered in the mortise, this is called the mortise, then it's a good idea to do a quick reduction under sedation, Entonox or whatever, before putting it into a back slab and then admitting, and then because this will clearly need internal fixation, but that X-ray is probably not good enough to support the story. Though you could say, well, she's got a sensory loss, so that's also a reason to try and do a reduction if possible, because that might take pressure off her superficial perineal nerve. Okay, but so I'm not going to be, I think the X-ray doesn't quite carry it. 32. 67-year-old man, new onset headache and drowsiness. History of hypertension, but his systolic BP is 220. He has papilledema. So what's he got? What's his problem? Malignant or accelerated hypertension. And what do we like best for that? And why do we like labetalol? What? It's not a standard beta blocker, is it? It's a
Got alpha and beta activity.
It has alpha blocking activity as well, because if you just block the beta, just like we talked about earlier with cocaine, you still leave the alpha activity of any catecholamines, and so you get this closure of splanchnic and skin vessels. But if you block both of them, you just generally open up all your vessels and allow the blood pressure to drop. So thank you online, that's the right answer. The cardioselective thing about beta blockers, we don't need to worry generally too much about that. Cardioselectivity really only comes in for beta blockers, which might also affect your airway obstruction. Yeah? Because if you use a cardioselective, you won't get airways obstruction. And if I have this right, I think all the ones in the first half of the alphabet are cardioselective. So atenolol, bisoprolol. But all the ones in the second half of the alphabet, like propranolol and timolol, are not. It's just by chance. Anyway,
We need an urgent CT to rule out any bleed before we start reducing the blood pressure, because you're drowsy and starting to take as well.
So there's a question in the room here as to whether an urgent CT would be a useful thing. Okay, but so he's got headache, very high blood pressure, drowsiness, and papilledema. And so yes, he could, I suppose, he could have. It's not a very focal story, is it? It's a bit of a.
No, that's right, that there's no focal neurological deficit.
Yeah.
Including the
Yeah, I think that's the answer. Yeah. Okay, 23. We see lots of chest X-rays looking like that, don't we? So here's a 63-year-old man, progressive shortness of breath. He's got a heart rate of 118, BP's a bit low, SAT's 94%, and here's his chest X-ray. So you've got to make some sort of judgment about what's likely to be wrong with him. He's got breathlessness and that chest X-ray. Which of these? Yeah, it's not a lot to go on, is it? Yeah, but I think there's enough there to say this is likely to be a heart failure with pleural effusions, isn't it? You've lost his diaphragms. Can you see you can't see his diaphragms on each side? So it's likely that there's something of water density against his diaphragms. And it looks from this like a pleural effusion. It looks like he's got a big heart. So heart failure seems the likely diagnosis, and diuretic would be the treatment. 34, 3-year-olds with 1 day of abdo pain and diarrhea with some blood in it, likely cause. Blood-stained diarrhea in a 3-year-old. Yeah, Campylobacter. Yeah, it's second commonest cause of bacterial gastroenteritis in the UK. And it's quite a painful diarrhea and may have blood in it. 86, I think we've already done this yesterday. She's got a thoracic spine fracture. Most appropriate action. Yeah, so in order to preserve your bones post-menopausal, you need to certainly have enough calcium, certainly have enough vitamin D. And of course, we now know that many people are vitamin D deficient, aren't they? Particularly in the winter. And the NICE are now recommending that everybody takes vitamin D across the winter. You know, we could have a quick straw poll. Does everyone do that or not? But they're now recommending everyone has vitamin D, because vitamin D promotes calcium absorption from the gut, and you've got to have enough calcium in your diet to absorb. So those are the first requirements. Keep looking after your bones. But on top of that, bisphosphonates will promote bone formation. So those are the requirements to look after your osteoporotic patients. Okay, this old man found in the morning, and this is what he looks like. What do you expect to find on his CT? Fairly straightforward. Yeah, everyone happy with that? Yeah, panda eyes, as they used to be called, typical of a base of skull fracture, along with things like, what are the other base of skull fracture signs? Mastoid bruising, often known as battle sign, hemotympanum, subconjunctival hemorrhage that you can't get behind, that keeps going backwards. Yeah. And you may have CSF leakage from the nose or from the ear. Good. Okay. Now this one, we had a bit of a debate about this question, but anyway, I've put it in for a reason. 22 is a young man, 2-day history of chest pain, exacerbated by inspiration, localized to an area just below the right nipple. Area is tender. His high sensitivity troponin has been reported as high. What are you going to do? Now, I'm probably won't get a question like this, but this was, I put this in for a reason. Okay, the point here is there are some tests that we use that have low specificity, yeah? And the low specificity means lots of false positives, yeah? And that's just D-dimers, the obvious example, and troponin, high sensitivity troponin is another one, where you catch lots of people who don't have a heart problem, who just have a raised high sensitivity troponin. And so if it's not used appropriately, this is why tests have to be used appropriately. If you just test everybody for their high sensitivity troponin, you get loads of positives. So you have to only use it for people who you think might have an ACS. It's only then that it's useful. If you use it for somebody who don't think has got an ACS, it's useless because you get false positives all the time. And that's really what this is illustrating. So, but I'm going to leave it because I think you won't get this question. And it was just really illustrating that point about low sensitivity tests.
Why can't A be the option?
I'm not going to. If you use markers inappropriately, you end up with lots of people being put on observation wards and being admitted who've not much chance of having the disease. And so you just fill up the hospital with people you don't need to. And this is why there's this real danger of having these battery of tests at triage. I don't know if you have that, but people doing tests, oh, I'll just add this, I'll just add, oh, it's come back positive, I was right. No, it might be a false positive. And that's the problem. But it's Dr. Ranjan.
Can we do a chest X-ray?
Yeah, you can. I mean, you see loads of these people, don't you, with costochondritis type pain, and there's no test will help you with it. But let's move on because it's that was the point I was trying to illustrate, was the point about using tests, low specificity tests, only in the right place. That's my point on that one. Okay, a 74-year-old left lower abdo pain past mucus, systemically well, but tender. No palpable mass, diverticulitis is suspected. Yeah, seem reasonable?
Yeah.
Somebody of her age. Most appropriate action. She's systemically well, but tender. Now, this always takes everyone by surprise, but it is a guideline, a national guideline. It is E. It is E. So people with acute diverticulitis who are well, we do not give them antibiotics. We just give them a safety net, tell them when to come back. So how do we diagnose it? We diagnose it clinically. We don't use imaging. So suspect it. If a person presents with constant abdo pain, usually severe and localizing in the left lower quadrant, with any of the following: fever, sudden change in bowel habit, or tenderness. Be aware that some people, including people from an Asian background, may get it more in the right lower quadrant, because they've got diverticuli in the ascending colon, the cecum. For people with acute diverticulitis who are well, consider a no antibiotic strategy, simple analgesia, come back if it gets worse or doesn't go away. Offer antibiotics if they're systemically unwell. Okay, so it's another of these antibiotic stewardship trying to push down antibiotic use things. Okay, question at the back.
If they're having fevers for 3 days, does that come to being?
Well, it's your judgment as a patient. I think if I saw the patient and they had a temperature of 38 or something, you'd give antibiotics, wouldn't you? Yeah. But if they're just it's sore, oh, it's a bit tender there, but I feel all right, then you think, okay, well, this is what's wrong with you. Explain it, and then say it'll get better in a few days. Okay, and then you'd go on to talk about diet, wouldn't you, and stuff like that. Okay, 39. This guy had an insect bite 4 days ago, and it's gone horrible. What's he got? Necrotizing fasciitis. Yes, it's one of the causes, actually. So quite often it can be surgical, around the perineum, around the lower abdomen, but it can also be insect bites and other breaks to the skin. "40. She's been found collapsed, elderly lady, mild dementia, diabetes, and AF. And those are her regular medications. These are her blood tests. And unfortunately, you do have to read them and watch out whenever you see blood tests for the bit that's to attract your attention. And obviously, the potassium is the one there. And which of her regular medications would most influence your immediate actions? Digoxin is the right answer. Why? Because in the setting of hypokalemia, toxicity is much worse, isn't it? I mean, she might not be digitoxic, but she's had diarrhea, which suggests that she might be. And digoxin toxicity is always worse when there's hypokalemia. Okay. 41, 5-month-old, swollen, bruised right ankle, and this is his X-ray. It's just a spot diagnosis type X-ray. NAI, yeah. Anyone know the name? What's this called? It's called a corner fracture. Corner fracture. This little fracture here, and the idea is that you remember that that's the part of the bone called the metaphysis, where it's widening. You're right at the very end of the ossification, where the bone's very thin, yeah, because the bone is growing there, and the periosteum around it is stronger than the bone. And if you get twisting, this sort of action, the angry parent, really angry with the child, the periosteum can pull off a bit of that very fragile growing bone, and that's called a corner fracture, or bucket handle tear is another name for it. Okay, so an old man lives alone independently. He's not opened his curtains, and the family go around. They say he's quiet, inactive, and not responding normally to questions. Yeah, so that's what I'm getting at there, is hypoactive delirium. So as I touched on this yesterday, there's lots of delirium in hospitals, isn't there? About a quarter of patients in hospital have delirium. A few of them have hyperactive delirium, shouting, down the ward, etc., giving the nurses a complete, nightmare. But most of them are hypoactive. They've got clouding of the consciousness, but they're quiet and withdrawn, and they just sit there inactively. And we'll talk more about delirium. "60-year-old with schizophrenia brought to ED from the nearby psych unit with several episodes of feeling faint. You look at her vital signs and they look all okay. And this is her ECG. And what's the answer? What's happening to her, do you think? Why is she getting dizzy? Yeah, she's getting episodes of arrhythmia, which could be torsade, or it could just be, it could be VT, could be monomorphic VT, because they also get that. But you can see on her ECG here, this from there to there just looks really long, doesn't it? Yeah, if you look from the Q to the end of the T, just looks really long. Even without calculating it, it just looks really long. "44. Young builder, vigorous physical work on a hot day, and his temperature's 41.2. It's A, isn't it? It's cooling. Let me just say a little bit on this subject. So there are two conditions associated with hot weather and getting overheated. One's called heat stroke, and the other's called heat exhaustion. So the idea is that if you are generating a lot of heat, muscular activity, particularly because you've got big muscles, you're a young soldier or a builder or whatever, generating a lot of heat, but you can't lose it fast enough because maybe you're not used to sweat, you don't live in a hot country, you're just not familiar with it. So you can't lose heat well enough, or you're overdressed or whatever, or you're in military uniform. You start to heat up, you start to heat up, you start to heat up, and you sweat a lot. And you feel dreadful. And if it might get so bad that you start falling around, but you still think straight, you're not confused, and that's called heat exhaustion. Yeah, and the temperature can get up to 40, but you're still cognitively you're normal. That's heat exhaustion, and you're sweating. But as you get even hotter, the sweating switches off, doesn't it? Somewhere around 40, 41, you lose the ability to sweat. And what happens then is you get into an upward spiral. Heat generation speeds up your enzymes. Enzymes go faster, generate more heat, and you just go up and up and up. And you start getting all of the complications of heat. Yeah, and that's heat stroke. And the features of heat stroke are confusion, aren't they? Seizures, acidosis, DIC, disseminated intravascular coagulation, rhabdomyolysis, renal failure. Yeah, dreadful. Really rapidly get into serious trouble. So you go over a tipping point where it just goes worse and worse and worse, and you quickly get really seriously ill. And I'm sure you all are aware of, always been stories of marathon runners. There was an incident about 5-6 years ago of 5 young army recruits all died in Wales on a hillside, all died within an hour or two, the same condition, running with loads of kit. So that's heat stroke. Treatment, well, the first thing to do is cool them down rapidly, and it's usual to put ice packs on the big veins, isn't it? Neck, axilla, and groins, if you can get ice packs. If you can, or immerse them in cool water if you've got such a facility. But the next thing to do is often to paralyze them, intubate and paralyze, because that switches off muscle activity, because it's the muscle activity that generates the heat. Okay, so that's heat stroke. Let me put that on one side and talk about 2 other heat conditions. One of them is an anesthetic condition. Certain anesthetic agents in predisposed people with a genetic abnormality also trigger a muscle problem. And what's that called? Malignant hypothermia. And that's treated with dantrolene, which is a muscle relaxant. And there's another related condition which occurs in psychiatric patients, isn't there? Particularly with traditional classic antipsychotic medication, and that's called the my mind's gone for a blank. Neuroleptic malignant syndrome. Yeah. So and that's also muscle generated heat, and they get rhabdomyolysis as well. So these are the three conditions, all in distinct settings, all with different names. Yeah, but they all have this common factor of heat. Okay, and last question in this paper is come in because his food and saliva are dribbling. That's the only thing that's wrong with him is his face. Which of those? So is it upper or lower motor neuron? It's lower. How do you know it's lower motor neuron? Because that's important. So he's got a, what's he got? He's got a, what's his face got? Yeah, he's got a facial palsy, hasn't he? We have to be careful not to jump straight to Bell's because that's only one possible differential. So he's got a facial palsy, hasn't he? So it's his seventh nerve, his facial nerve, not operating his muscles of facial expression. And we know it's lower motor neuron because it's upper and lower face, isn't it? Because upper motor neuron, if it was a brainstem stroke, he'd get upper face sparing, wouldn't he? And you'd still have creases right across his face. Yeah, you all know this, don't you? Yeah. So, and then causes of low motor neuron, you know all of those, don't you? Bell's palsy, of course, often has pain, you know, behind the ear for a day or so before it happens. But you've got other causes in the parotid, in the middle ear, you know, acoustic neuromas, etc. Good. Okay. And the treatment for if you think he's got Bell's palsy is there's some evidence that steroids helps if you see it early enough. So steroids. Okay. It's 10 to 10. If there's no burning questions on any of that, let Anupa.
Thanks, Ian. If the symptoms were more than 3 days and prednisolone was an option, would you not go for that? Would you go?
I haven't got an answer at my fingertips, but I think it's one of those things that steroids only work for the first 2 or 3 days, but I can't tell you an answer and say this is the exact cutoff. It's been one of those things that's been debated for years. I think the benefit's only quite marginal anyway of steroids. It's not massively helpful. You know, when I was in medical school, the view was nothing helps, but it's swung around a little bit over the years. So I can't give you a categorical answer. I don't know even if there is one. Is that all right? Sorry. So there's Karen's reading me something about question 32. Okay, so this is the question that we also had in the room here. The question is, what about CT for you know, secondary causes of headache? I think we talked about that really because the patient has no neurological features. There's enough. I think there's enough evidence there to say that this patient's got accelerated hypertension. I think, but you know, it's very hard to avoid totally. You know, some sort of, well, yes, but in some circumstances, this might be the right answer. There is another question, which is even if you had a stroke, would you not bring the blood pressure down? And that's another interesting debate. And there is some evidence that bringing down blood pressure a bit when it's very high can be useful. So even, you know, so I could defend the answer in that way. But I don't think he does have a stroke because he's got no neurology. Okay, let's move on to question paper 4. Okay, so it's 5 to 10 now. Should we roll the break into it? Could we come back at 11:05? Is that all right? So do paper 4, grab a coffee and come back for 11:05. Is that all right? Can people hear me at home?
Yeah.
Great, thank you. Good. Okay, paper 4. 68-year-old man drooping of the face, which has got better after 20 minutes. So it would have been calculated an ABCD2 score in the past, but that has gone. We used to work out high risk and normal risk. High risk 1 day follow-up, normal risk up to 7 days. But now everybody's on 24-hour follow-up, aren't they? Everyone should be seen within 24 hours.
When did this change? Is it something very recent?
I'll show you when it changed in a moment. The question here is, when did it change? It's more than a year ago, anyway.
Because we're still following this in a hospital. Honestly.
64-year-old woman, weakness of the right side of her face and right arm. Difficulty speaking. So right-sided features, and 5 hours ago. CT, no hemorrhage or established infarction. Right answer? So she's outside the window for thrombolysis. Which territory is her stroke in? It's left.
Yeah.
Which? Middle, isn't it? Middle cerebral, face and arm, yeah. And so proximal middle cerebral territory is maybe accessible to thrombectomy, mightn't it? So she's a candidate for thrombectomy, all right? I'm not going to spend time just going on the neuroanatomy, but you may have questions which require you to know a bit about the territory: anterior cerebral, middle cerebral, posterior cerebral, basilar territory. And of course, this is the internal carotids becoming the middle cerebral. And this territory here, what's known as the M1, or the horizontal segment of the middle cerebral, is where thrombectomy works best. So where the infarct is important. And just a reminder that the left hemisphere is dominant for most people. If you're right-handed, your left hemisphere dominant. If you're left-handed, it's split, 50-50. And if you're left hemisphere dominant, your speech areas. So Broca's, which is expressive, and Wernicke's here, which is receptive areas, are on your dominant hemisphere. So here is the guideline, May 19 is the guideline, in answer to your question, when did this come in? So this is TIA management, aspirin, and follow up within 24 hours, which is this there. Don't use ABCD2 score. So it went out with that guideline. Okay, so that's, I think, all I need to say about TIA. Just a couple of things on thrombectomy. I want to bring out a few facts on thrombectomy. First, so these two guidelines here, this one refers to within 6 hours, this 6 to 24. So within 6 hours, yes, if it's ischemic and there's no bleeding, it's a possible candidate. If it's 6 to 24, there's got to be potential to salvage brain tissue. So there's got to, it mustn't be a large established infarct. If it's all dead, no point. But if there's some salvageable brain, and we don't need to get into how can you judge that on a scan, but they can. They can judge how viable, people talk about things like penumbra and stuff like that. So they can judge that. So if there's salvageable brain, even up to 24 hours, thrombectomy may be considered. And this, for example, includes wake-up strokes, the person who's woken up with a stroke and they don't know when it happened. So that's about timing. And then another factor, so to be eligible for thrombectomy, it has to be a non-hemorrhagic. The timing criteria has to be reachable, which usually means middle cerebral or sometimes posterior cerebral. I haven't touched on that, but there are some reachable, because you've got to wiggle this gadget right up into the artery. And sometimes in the posterior circulation, it may be. But there's two other criteria, which are these two here. Basically, you needed to have been quite healthy beforehand. That's what the Rankin score means, and I'll show it in a moment. You needed to have had only a minor disability. You know, so if you've got a bit of arthritis, that's okay. But if you've got dementia, that's not okay. That would rule you as ineligible for thrombectomy, and I'll show you why. I'll show you in a second. And it's got to be quite a bad stroke, not a trivial one. If it's a trivial stroke, that's also not eligible. So this is the Rankin score, and basically you've got to be below 3. So if you're 0 or 1 or 2, you're still eligible. But if you're 3, requiring help, etc., you're not eligible. And the stroke scale, we don't need to know about this, but you have to be 5 or more, moderate to severe stroke. So it's got to be bad enough to warrant doing the procedure. Is that okay? Any questions on thrombectomy?
Just as that was reworded,
And I'll come to you in a second.
Talking about anterior circulation, to say it wasn't middle cerebral, it was like anterior, like the leg.
Okay, anterior, there's a question here about anterior circulation. Anterior circulation refers to both middle and anterior cerebral arteries. So if you have a very, very proximal lesion, if you've got a clot before the bifurcation to anterior, that would also be reachable. That's what would be called a total anterior circulation stroke. Yeah, so even more worth it because they have dense, really dense strokes. Yeah, so it's not just middle cerebral, it's also, yeah, you're quite right.
Yeah, so in this patient, the CT scan was basically normal. I would expect that before thrombectomy we would do another imaging, like MR.
No, you can make the decision on CT alone. You can make the decision for thrombectomy on CT alone, I believe. Yeah.
Yeah.
I mean, the issue will be if you're over 6 hours, because then it's, you know, is there anything, any brain there that's damaged but not dead, which could be salvaged. If it's all dead, and that's where I'm not quite, I have to admit, I don't exactly know how they judge that. And that might require additional imaging, but under 6 hours, it's that. I'm just quoting the guideline. So under 6 hours, it should be no more than that. Okay, I'm going to move on to number 3. So this is about C-spine. So he's been hit from, this is a driver sitting at the junction, whack, somebody's hit his car from behind. He's sitting when you see him. Has a normal upper limb neurology, but midline tenderness. What should you do in terms of imaging or not imaging or whatever? Was that you? Back there? I've been offered A. This is about the Canadian C-spine rule, which NICE have adopted. And you're right, it's A. So why is that? So I'm going to just, if you're not familiar with the Canadian C-spine rule, it is a little bit fiddly. It's a little bit complicated, but let's just go through it. So this is it. And I'm going to go through it a bit at a time. So you enter at the top left. So the first question is this. Are there any high risk factors? So here's this person, they've got a neck pain from a trauma. Are they over 65? Are there any paresthesia in the extremity? They've got a numb arm, numb leg, so neurological damage, suggesting they've got damage in the neck. Or is it a dangerous mechanism? So what does that mean? And so here's the list. Fall from more than 1 meter or 6 stairs. Axial load, that means pressure down through the body, for example, diving into the sea or a swimming pool. High-speed road accident or ejection. Quad bikes, sort of thing, or bicycle, you knocked off your bicycle. Any of those would be a high risk and would warrant immediate imaging. Usually X-ray. Okay, so, all right, over 65, paresthesia, high-risk injury. What about if you haven't got one of those, which is, of course, most people? What are you going to do next? Well, the next thing you do is you go to this box here, which is the low-risk criteria. So has the patient got any one of these? You don't have to have all of them. And this is where people struggle with this algorithm. Because you only have to have one of these. So, was it a simple rear end accident? Well, yes. Good. That's a yes. Or is he sitting? Well, he is. Or has he been walking around at any time? Well, he probably has from the story. Did he have delayed onset of pain? Or absence of midline spine tenderness? If you've got any one of those, you go to a neck rotation test. If you haven't got any of them. So what do I mean by that? So for example, just because he's got midline tenderness, yeah, if he's got that, then it doesn't matter because he fails that test, he still passes some of the others. Does that make sense? And that's where people struggle with this guideline. They say, well, he's got midline tenderness. He says, well, it doesn't matter. He's been ambulatory. It was a simple rear end shunt. He's been walking, he's sitting. Any one of those is enough to do a neck rotation test.
So if you failed 3 but passed 1,
Yes,
you would make
that's exactly the point. You only have to pass one of those to progress to the next rotation. If you don't pass any of them, imaging. But if you pass one of those, any one of them, then you go to this box here, rotating, and the neck rotation test is 45 degrees left and right. Okay, and if you pass that, no imaging. You may have come across the nexus rules, yeah, which is where people sometimes get confused, because nexus rules, if you fail any one, you get an X-ray, midline tenderness, neurology, distracting injury, drunk, alcohol or drugs. I've missed one out. But the nexus rules, you only have to fail one to get an X-ray. And nexus rules led to many more X-rays than this Canadian, which is why they've adopted the Canadian, because lots of people have midline tenderness. Okay, is that all right? So that's the Canadian C-spine rule. That's the rule you should apply. There's a separate CT rule for, okay, when is it CT rather than X-ray? And which I won't touch on at the moment, but that's the rule about X-raying necks. Okay, number 4. Okay, 17-year-old found unconscious at a party. He's now recovered. He says, well, I hadn't drunk much, or I certainly hadn't taken anything. Which of the following would be most helpful? So when he goes for follow-up in the neurology outpatients, the first fit clinic, he's not confirmed to have had a seizure. Which of those is going to be most helpful? It's witness history, isn't it? It's actual story from a witness is the most useful thing. Number 5, sticking with seizures, 3-year-old, continuous seizures from an underlying syndrome. The patient has already had 2 doses of lorazepam. Yeah, phenytoin is the next line, isn't it? And that comes from this guideline, which was updated last year. So this just does it as a time sequence. So you've got some options. Remember, you can give lorazepam, 0.1 milligram per kg, or buccal midazolam, 0.5, or rectal diazepam. Then you repeat it, and if that fails, you're onto phenytoin. Or phenobarbital is another option. Number 6. So 87-year-old collapsed. Triage nurse thinks it might be sepsis. Which of the following are high-risk criteria? Yeah, so there's and we'll have a look at them. So new altered mental status, there's some respiratory and cardiovascular, but that one, you're absolutely right, is a red flag. 78-year-old worsening cough and lethargy for 3 days. Here are her vital signs. She's got a fever, a bit hypotensive, tachycardic, lowish sats, venous gas, so the PO2 we can't really take account of, but she's slightly acidotic. PCO2 is fairly normal, bicarbonate's not too bad, lactate's up a bit. That's a pretty easy one, isn't it? A, yeah. Number 8. So here's another sepsis. He's been given 2 liters of saline, but he's still hypotensive. Yeah, noradrenaline, everyone happy with that? Yeah. Alpha agonist. Acute myeloid leukemia presents with fever and hypotension, so assumed neutropenic. Which antibiotic regime for empirical therapy? You've got a neutropenic sepsis. Bit of a spread of opinion there. Anyone feel strongly that they know? Yeah, so you don't use gentamicin, so it's E. I'll show you the guideline in a moment. It's that. So just some stuff from sepsis. Now, the sepsis guidelines are really annoying because they've changed them a lot, because they're trying to protocolize what is a really mixed bag of different patients. But this is where we are at the moment. And the things that matter with sepsis are thinking about it. That's probably one of the biggest things, is thinking, I wonder if this is sepsis. And so they've tried to put that to triage, getting people to think about it early, and then getting on with it quickly, fluids and antibiotics. Those are the things that matter really with sepsis. And so all the emphasis is on recognition and early aggressive treatment. So that's really underlying all of the detail. That's what it's really about. So this is, if you have a high risk criteria, those are the things you should do. They should be seen by a senior, and they should have blood gases, blood cultures, etc., and broad spectrum IV antibiotics within an hour. So you all know that. We called it the sepsis 6, but then they took away catheterization, so it's become not quite 6 anymore. But it's still the same concept. So who should you consider for sepsis? Well, don't forget people on chemotherapy. That automatically makes you a red flag sepsis. You've got features of sepsis and you're potentially neutropenic, even if you don't have the results back yet. And then, what are the features of red flag sepsis? So the nurse at triage says, I think this patient might have sepsis. How are you going to decide it's red flag, which means you then do the sepsis 6, including calling a senior decision maker? Well, it's that list, which we've already looked at 1 and 2, heart rate over 130, systolic less than 90, new altered mental state, up there, isn't it? Respiratory rate over 25, needing oxygen to keep the SATs above 92, or looking dreadful. So those are your red flag sepsis features, which get you the sepsis 6 or sepsis 5 now. And what should you give people? Well, if they've got neutropenic sepsis, give them beta-lactam. So this is basic PIP and TAZ. So tazocin, I think that's often known as. Piperacillin and tazobactam is like coamoxiclav, but up a step. It's the same idea, isn't it? It's a stronger broad-spectrum penicillin plus another penicillinase inhibitor, more powerful penicillin. That's the idea. Don't use aminoglycosides. So gentamicin is an aminoglycoside, so you shouldn't use them empirically in neutropenic sepsis. So that's the justification for that answer. Okay, is everyone all right? That's a quick run through some bits of the sepsis guideline.
Quick question, sorry.
Yeah, sure.
Any reason why we don't give Hartmann's in question 7? Or is it just normal saline because it's over 15 minutes?
Sorry, was question 7?
Yeah.
I think it's the volume.
Okay.
It's the volume. It should be 500 would be your bolus. It's not because of the Hartmann's. And there's an ongoing debate as to whether Hartmann's is superior to normal saline, and it possibly is. It possibly is, although it's quite marginal, I think. 10. 3-year-old, fever for a week, rash, erythema of both eyes, and lymph nodes. Here's a rash. Yeah, so what's the diagnostic criteria for Kawasaki's? Fever for 5 or more days, plus, remember there's no test for Kawasaki's. You can't send off the Kawasaki's test and see if it comes back positive. It's a clinical diagnosis. Long fever, plus out of rash, lymph nodes, mouth, strawberry tongue, redness, cracking, eyes, redness, and fingers, swelling. You've got to have all except one. Yeah. So is that 5 out of 6? So rash, lymph nodes, eyes, mouth, 4 out of 5. You've got to have 4 out of the 5 plus a long fever. You have to have the long fever. Okay, what's the risk? Untreated? I'm sure you aneurysms of the coronary arteries leading to infarcts, which have a significant mortality. So it's serious if not treated. And treatment, mainstay of treatment?
IVIG.
IgG, yeah, online immunoglobulin or high dose aspirin. Good, okay. So we've got a couple of other questions which now should be straightforward. 3-year-old, she's come back 3 times with a fever, rash on the chest, painful swollen fingers, eye discharge following visit of the tongue. So in other words, what haven't we got so far? Lymphadenopathy, yeah. This is another 3-year-old with Kawasaki's. Parents want to know what he's going to be given. Yeah, and the answer there, of course, is immunoglobulin, IgG, or it would be high dose aspirin, but that isn't offered. Okay, so you've got to have four out of those. So untreated mortality of about 2%. So it's quite a serious disease. 13. So it's another asthma question. So he's 34, he's bad. He's had 5 lots of nebulizers. He's also had ipratropium and IV steroids. He's still distressed, SATs of 92%. Yeah, so magnesium it's a smooth muscle relaxant, works on the bronchi, and so 2 grams of IV magnesium would be an appropriate next step. And we'll look at the guideline. Okay, another asthma. 17-year-old, managed for 2 hours, not getting any better, nebulized salbutamol and oral steroids, and you've taken an arterial blood gas. And if we do that in an asthmatic, which is the bit that we are mostly concerned about? CO2, yeah. So generally speaking, what should you find in an asthmatic? You should find a low CO2, shouldn't it? Or right at, so if this is the normal level, and here's, you're going across the severity categories, it should go down, shouldn't it? And stay down right to the very severe when it comes back up to normal and then high. So with her, she's got high normal, hasn't she? So that's a marker of severity, isn't it? That's a marker of sort of life-threatening asthma. We'll look at the guideline in a minute. So what you're going to do out of that list, yeah, get the anaesthetists involved. Okay, this is not such a bad asthmatic, but you've got a peak flow here of 370. Yeah, go ahead, Gunasagaran.
About question 14. Why we didn't try with intravenous magnesium sulfate?
Okay, it's not a bad treatment, but the point is here, this is somebody who's now at risk. And so that for safety reasons, you would want to have anesthetic help to hand. Yeah, that's the point. This blood gas is telling you this person's at risk. So magnesium is, you might get the anesthetist down and then you might decide to give some magnesium and see if that works, but you want to do that. It's about being prepared. Does that make sense? That's
okay. All right.
You don't want to be caught out. So vital signs aren't too bad, bit of a tachycardia, that's all really. So the question is here, how do you interpret the peak flow? What is the normal peak flow roughly for a 27-year-old male? So if you asked all the guys in the room here, what's your peak flow? Or ask the girls.
600?
Yeah, guys, healthy young men should be around 640, something like that. And healthy young women should be about, of average height, about 480. Yeah, 460 to 470 to 480. Yeah. So it depends on gender and age. It peaks when you're about 30 to 40 and goes down after that, and height. Okay, so if he's got 370 and he's predicted is 640, then he's over 50%, isn't he? That's the point here. It's over 50%. What would that categorize his asthma as in the 4-category system? Moderate, which is 50 to 75. Yeah, so he's moderate category. So yeah, A. Salbutamol as a nebulizer rather than as an inhaler, which would, okay.
Why, sorry, I didn't really get, I thought you could still have a healer, but it wasn't an option. Just, is that all the thing you read about the moderate? I still thought you couldn't have a healer, but that wasn't an option.
We'll go to the guideline. There's a question in the room here about using inhalers instead of nebulizer, but we'll go to that. It's slightly different between adults and children as well. Another asthma question. She's got worse. Long-standing. She just gets the occasional attack. It's got worse now. And you ask her to, have you taken any medicines recently? Which of these could be relevant? Yeah, non-steroidals couldn't they? So here we go. You know, I've just suddenly realized I may have to change what I've just said. Right, so here's the BTS guidelines for asthma. And we haven't got mild here. Mild is missing, which is over 75%. We've got moderate, severe, and life-threatening. Okay, and we're going to follow those columns down. So you decide which they are by their presentation, by peak flow, or by clinical features. And so there are clinical features here. So severe, again, we've got this phrase, can't finish a sentence, makes you severe. Yeah, you have to stop to take a breath halfway through a sentence. And again, life-threatening is you look exhausted, you're cyanosed, you're confused, hypotensive, that sort of thing, silent chest. That's the life-threatening. And then moderate is the 50 to 75%. So that's moderate, yeah, that's severe, and that's life-threatening. So let's follow those down to what we do. Now, I think I'm actually going to go, you're actually right. Moderate, you can give inhaler. So that is actually the same as with children. So my question was wrong. An inhaler would have been fine. So for a moderate, you can use an inhaler. For a severe, you should use a nebulizer. And for life-threatening, you should give salbutamol and ipratropium. Give them both. Otherwise, you only give one first. Okay, so for everybody, they get steroids at some point. So I won't. Here's the steroids for the moderates and the severes, or actually on discharge. But here is the steroids for the life-threatenings. And then just going a bit further down with the life-threatenings, you do a blood gas, and you look at the CO2. And it says here, markers of severity, normal or raised CO2. And then what else might you do? Well, for the life-threatenings, repeat the salbutamol and the ipratropium. Consider continuous nebulizers, IV magnesium. Yeah, and it's also got chest x-ray and repeat blood gas. What about right at the end, discharge? So I think the things I wanted to point out about, there's various criteria for discharge, you know, how much they improve, etc. But it says here, steroids for 5 days and GP in 2 working days on discharge for everybody who gets sent home. It says here, steroids only for people of severe and worse. I thought it included moderates. I'm not quite sure why it hasn't got. Is that because it was given there? I thought moderates also got steroids, so I'm just gonna duck that. I haven't got it shown here, but I thought moderate severity also had steroids. Kimani.
If you go back a slide, it says that the moderates with a peak flow of less than 75, you give prednisolone orally. 15 to 20 minutes. So does that mean that question 15, the answer is C?
Well, I think we've established that A should have said inhaler, salbutamol by MDI would be the first treatment, because steroids, how long do steroids take to work? They take 8 hours, don't they? Because they work through a second messenger, so they don't work quickly. So I don't think they would be your first action. But I take your point, should have steroids. Okay, let me move on to eyes. 1 day history of right eye pain and blurred vision in an old lady. Okay, so she's got an oval pupil, hasn't she? She's got a funny shaped pupil, which makes you think of open angle closure glaucoma. Yeah, so that's the right answer here. What about this one? If you look really closely, what's the shape of his pupil? What's that? What do you think that might be? Have you heard of posterior synechia? Anyone? There are adhesions between the iris and the front of the lens, and they're a feature of anterior uveitis. So this is anterior uveitis, or iritis, as it's also known. And so with them, you get a cloudy anterior chamber with cells in it, foggy looking anterior chamber. And you get these, if it's recurrent or if you've had it before, you get these adhesions behind the iris. Yes. Yeah, because if you dilate the pupil, it can't all open because some of it is tethered onto the front of the lens. They're called posterior synechia. Keratitis, this is basically a really serious infection of the cornea. So if he was actively using his contact lenses, you know, that you'd worry about that. And there are 2 organisms particularly. Anyone know? Something called an acanthamoeba nigricans and also Pseudomonas. Both of those can munch away from the cornea in contact lens users. So all contact lens users with sore red eyes have to be, because they're difficult to diagnose, have to be seen by ophthalmology. What about this one? This is a classic, what's it called? Dendritic. Dendrite is sort of tentacles or tree-like, yeah, which is a herpes infection. What about this one? Bit of discomfort in the eye. Oh, it's a bit sore, my eye, and I looked in the mirror and it was all red, but I can see all right. Yeah, episcleritis, yeah. Yeah, and then my eye may well feel gritty. And one of the things is if you get a cotton wool bud and you can move the blood vessels around, that's a feature of episcleritis. You can move them around, these distended vessels over the surface. And that separates it from choroiditis, you know, a deeper infection. Okay, so just a couple of other things. What's the clinical, I mean, this is a red eye with a small pupil, but what's the striking feature in that image, which they might show you?
Hypopion.
Yeah, hypopion, hypopion, which just means low pus. And when do you get that? Which uveitis, isn't it? It's white cells. It's a puddle of white cells. And so they have a cloudy anterior chamber, don't they? Because there's so many white cells floating around. And if you put your slit lamp beam across the eye, it's like, you know, headlights on a foggy day. You know, you just see like particles inside the anterior chamber. This one, I mean, we've already just seen that one. That's the glaucoma. Again, you could be asked about, you know, palpation. So you stand behind the patient, feel the eyes, normalize our squash ball consistency, but glaucoma golf ball, yeah, really hard. And they get edema. So if you look with a slit lamp, the surface of the cornea is cobbled instead of being flat because of edema, because the fluid can't drain. Yeah. And this may be paralyzed, unresponsive pupil. And we've done that one. 21. Okay, some chest pain stuff. ECG. Female, chest pain, 65, smoker, lowish blood pressure. Which drug might you avoid in her? Like that. GTN, why? Specifically, what's the issue here? The blood pressure might drop, yeah, why?
Could lead to cardiogenic shock.
Yes, it could indeed, but why? Which bit of the heart? So she's got an inferior infarct, hasn't she? And that particularly affects the right ventricle. And so her big problem may be a loss of right ventricular contractility, and they become very preload dependent. Yeah, if you need your right heart to pump blood through to your left, don't you? If your right heart's not pumping very well, and you're getting poor venous return, you're going to not get blood going through to the left side. Does that make sense? So they are so you can fill them up, and that may help if you've got a right-sided infarct. That may help to maintain blood pressure in a way that it doesn't with a left-sided infarct. But they're very dependent on anything that drops the preload, like nitrates or vasodilators. Yeah, okay. So that's the point there. Bit of an advanced point, but that's the. Okay, what about this one? So sudden onset chest pain 3 hours ago, and he's 2 hours from the cath lab. This is his ECG. Most appropriate management. So two of those. So firstly, he should get thrombolysis. Is everyone happy with that? Yeah, because if he can't get to a cath lab within 2 hours of decision, you do thrombolysis. Yeah, if he's got a STEMI within 12 hours of onset. Yeah, is everyone happy about the underlying principle? But you've got two thrombolysis options here, B and C. Which is correct? It's C, isn't it? You don't transfer him straight away, give him the thrombolysis, wait, and then repeat his ECG and still see if it's gone away. Yeah, if it's resolved, don't need to transfer him. But if it hasn't, you do. Okay, and we'll look at the guideline in a second. Okay, he's 64-year-old, 2 hours of central crushing chest pain. Here's his ECG. So what's the territory? Everyone happy? Right coronary, inferior infarct. Yeah, he's got some reciprocal changes in other leads, like in 1, AVL, and V2, but the primary lesion is 2,3 AVF. Yeah, everyone okay with that? So what's he going to be particularly at risk of? Yes, because right coronary usually supplies your AV node. So he's at risk of complete heart block. Another one, 67, chest pain, radius of the left arm, anxious, sweaty, and nauseated. Here's his vital signs, nothing too awful there. Here's his ECG. So with him, it's anteroseptal, isn't it? From V1, V2, V3 to V4. Yeah. Yeah, so his is more left ventricular, isn't it? And so he's at risk of pulmonary edema, yeah, of back pressure from the left side back through the pulmonary capillaries. He's also at risk of mitral regurgitation, but it tends to come a little bit later. Doesn't tend to come very acutely because dysfunction of the papillary muscles, etc. You can develop mitral regurg. Okay, 3-hour history of sudden chest pain. Vital signs aren't too bad, I don't think. His is ECG. Slightly more tricky ECG, but I think what it's telling you here is his primary problem is 2,3 AVF, and then you've got reciprocal changes again in 1 AVL and V1 to V4. So the answer is D, prasugrel, because he's going to go for a PAMI, isn't he? And he's going to need dual antiplatelet treatment, and so that's why prasugrel. We'll look at the guideline in a minute. Okay, 76-year-old man, 3-hour history of chest pain, hypotensive, ECG. And the question, so the ECG again, oh, to be honest, this looks like the same, very similar ECG, doesn't it? So he's got, again, it's inferior changes with some reciprocal changes. It's inferior, isn't it? It's inferior, but with reciprocal changes. So his problem is right ventricular contractility. Yep. Preload dependent. 64-year-old man, 1.5 hours of chest pain. Here's his ECG. This is just a spot recognition one. True posterior, yeah, everyone. So how do you know that? Well, you look at this lead here, don't you? And you imagine you had the ECG. Imagine I have an ECG in front of me and I do that with it and I hold it to the window. And so I've turned it, I'm looking from the back upside down. And so if you imagine what would happen to that, if it was upside down, look from the back, you'd see Q wave, ST elevation, T inversion. Yeah, that's how you do it. And then the proper way to do it is to do what? So to do V7, V8, V9. They're all level with V6, aren't they? Just curve it going around the back. And look at the heart from behind electrically. Yeah, so here we've got them here. So this is what you get in V2. This is the same thing, Q, ST elevation, T wave inverted, looked from the back. But if you actually put the leads around the back of the patient, that's when you see the ST elevation. Okay, everyone okay with that? That's how you do posteriors. So let's just look at the guideline. Guideline was revised in November, just not very long ago. And helpfully, they've put everything into, they call them these visual summaries, one for STEMI, and which is this one, and one for non-STEMI. And if I just very superficially go over this, so STEMIs all get aspirin, unless they've got a strong reason not to. And then the first thing to decide is, do they get revascularized or not? A few people might not for whatever reason, but mostly they will. And then you've got the choice, PAMI or thrombolysis. For both of these, it's got to be within 12 hours. Yeah, and of course, thrombolysis only if you can't do a PAMI within 2 hours. And then it gets into what other drugs you use. A lot of this we don't need to know about. It's like whether you go for radial or femoral and stuff like that. But when we look here, you'll see that prasugrel should be given to anyone who's going to go for drug therapy for a primary PCI. So that's where the prasugrel comes from. Okay, and that's the STEMI. This is the non-STEMI. Looks very similar. Couple of differences. Non-STEMI, everyone gets aspirin, but everyone also gets what's known as an antithrombin, because it acts on antithrombin 3, so which is the heparin, low molecular weight heparin, fondaparinux family. And so generally it'll be fondaparinux, apart from under certain circumstances like kidney disease and things. So aspirin, fondaparinux, and then this stage here is grace scoring. Is that what your hospital does? Many hospitals do, where you decide what's the risk with this patient. Are they high risk, more than 3% mortality in 6 months, I think, in which case they go to this side, or low mortality, they go to this side. And then based on that, so you give them medical therapy and make a decision about PAMI, whether to go then for angiography. Okay, so just to bring out a few things that we've seen within that. For people with STEMI who are having primary PCI, offer prasugrel, and then there are some exceptions, which we don't need to go into the small print, but that's why prasugrel. Fibrinolysis, if you can't do PCI within 2 hours. And then if you've done thrombolysis, do an ECG 1 to 1.5 hours after the thrombolysis. For those who have residual ST elevation suggesting failed coronary perfusion, then you transfer them. Okay, so that's failed thrombolysis. All right, the ST elevation is still there. Everyone happy with that? Okay, is that okay? Quick run through STEMIs. We'll come back to non-STEMIs. Right, what have we got here? So 9-year-old, abdo pain and vomiting. Ketones of 5.4. That's pretty sporting, isn't it? That's very high. And here's her venous gas, and her glucose is 26. And she's got a pH of 7.14. Now, what's she got? DKA. And which severity category is she? So she's severe, isn't she? So 7.1 to 2 is severe, 7.2 to 7.3.
Less than 7.1 is.
Oh, sorry, 7.1 is severe. 7.1, 7.2 is moderate. So you are right, it's moderate. So most appropriate initial action. So let's go back. So to decide this, we need to decide if she's shocked or not. She's not shocked. So if she's not shocked, then what does she get? If she is shocked, she gets 20. If she's not, she gets 10. Okay. 29. 9-year-old boy, vomiting, now lethargic, bit of a temperature, tachycardic, low blood. Even for his age, that's even for a child, that's low, isn't it? You expect it to be at least 88 systolic. He's got an extended capillary refill, so he is shocked. Venous gas, here we go, here we go. This is a severe, isn't it? Less than 7.1. Glucose only 13, not very high. Yeah, everyone happy with that? DKA, even though the sugar's not very high, he's just got lots of the acidotic side, not so much of the hypoglycemia side. So 24 hours after iron, you would generally speaking be in the metabolic acidosis phase. So you certainly could be in the metabolic acidosis phase, but it doesn't particularly push your glucose up that I know of, or give you the temperature is probably related to the underlying cause. Also, I could be cheeky and say, well, it's not very common compared to DKA, isn't it? Because it's what's the most likely explanation. So I could be cheeky. I think if anything, iron poisoning would give you a low glucose because it affects your liver. and you would, which is where you maintain your sugar from. So I don't think it's iron.
But would you get a fever if you get it? That's why I thought it was septicemia, because I didn't need to do it. That's what put me off DK.
Well, DK has got to come for a reason, hasn't it?
Okay, so you're just okay.
It's not enough reason to reject it anyway. A 12-year-old gets recurrent DKA. This time he gets drowsy and agitated. What's the point here? Cerebral edema, and though the treatment for that is hypertonic saline. Good.
Sorry, what was the answer to 28?
28. So this is the 10, isn't it? So this is somebody who's not shocked. So if you're DKA and you're not shocked, it's 10. And it comes out of your calculation. If you are shocked, it's 20, and you get that as an extra. And you get the calculation as well. We'll come to the calculation in a minute. Right. Okay, so 6-year-old, type 1 diabetes, pH 7.15, bicarbonate of only 9, glucose of 13, ketones 3.4, most appropriate initial management plan. So as distinct from adults, with children, we give the fluids first, yeah, don't we? And then we give the insulin 1 to 2 hours later. So we first of all have to just check he's not shocked. He's not shocked, so he doesn't get the 20 bolus, doesn't get this one, he gets the 10 bolus. So it's not this one, so what other options? Well, it doesn't start insulin infusion, so you can cut those two out. You can cut out that, so it's either A or C. And so you haven't got his potassium yet. It's going to have to be A, isn't it? Okay, so this is the British Society for Pediatric Endocrinology and Diabetes, from whom we get the pediatric diabetes guidelines, unlike Diabetes UK, who do the adult ones. So they look a bit different. And so in terms of diagnosis, you don't have to have sugar for children. You just have to have acidosis and ketones. So unlike, so you just have to have the K and the A, not the D. And then severity category, you've got 3 severity categories: mild, moderate, and severe, all based on the pH. So less than 7.1, as you rightly said here, is severe. And that then determines how much fluid to give, doesn't it? How much dehydration you assume they have. So if they're shocked, they get a 20 bolus, which is an extra. It should not be subtracted from the calculated fluid. Everyone else gets 10, which is subtracted. I don't think they're going to get you to do complex fluid calculations. You'd be relieved to know there won't be time, but just so you know. So fluid deficit, if they're severe, you assume it's 10%, which is here. If it's moderate, you assume it's 7%. And if it's mild, we assume it's 5%. So let's just quickly run through that. What would you do with that number? Let's imagine you've got a moderate DKA and you're working out the deficit. What's the calculation? So I'll give you the 7. 7 multiplied by weight multiplied by 10. Yeah, that's the calculation for deficit, just for deficit. So if it was a 4-year-old, well, the weight of a 4-year-old is 4 times 2 is 8, plus 8 is 16. So it would be 7 times 16 times 10. That would be your deficit calculation. How quickly do you give fluid? You do this calculation. How quickly do you give them the deficit over? 48 hours. Yeah, usually dehydration we'd give in 24, apart from DKA when it's in 48. You've also got maintenance, which we haven't, which is this one. So the maintenance, this is the same formula that you use for everyone else. There used to be a different formula for maintenance for diabetics, which was really mean, but now they've changed it to the same holiday SIGA formula. Everyone familiar with this? First 10 kgs, second 10 kgs after that. So 100 per 24 hours per kg in the first 10, 50 for 24 hours per kg in the second 10, 20 thereafter. Or if you do it per hour, 4 to 1. 4 mils per kg per hour for the first 10. Yeah, is everyone comfortable with that? It's on there. So a little bit about potassium, not rushing to give potassium until you know you're safe. Kanishak.
Hi, Dr. Stell. Could
Hi.
you please repeat the formula for the fluid deficit?
Yes. So it's the same for diarrhea and vomiting, for example, or any other dehydration in children. So if you imagine, in the first year, most babies are under 10 kgs, aren't they? So in the first, under 10 kgs, it's just for each kg, you multiply by 100, yeah? So a 10 kg child would be 10 times 100, that's a litre. That's how much you would give them, maintenance per 24 hours, 1 litre. Once they're over 10 kgs, for the additional kgs, so for 11th, 12th, 13th, 14th, they just get 50 mils per kg per 24 hours, yeah? So a 12 kg baby would get a litre for the first 10, but only another 100 for the next 2, making 1100 per 24 hours, yeah? And that works up until you get to 20. After 20, you only earn another 10 mils per kg. So a 24-year-old, a 24 kilogram baby would get 1,000 and 500 and 200. 1,500, 200, which would be 1,700 per 24 hours. Do you see what, that's how it works?
Yeah.
And then you divide that by 24. But the same formula, you get the same result if you give them, if you work it out by hour. So what am I going to give in the next hour? 4, 2, 1. 4 for the first 10, 2 for the next 10, 1 after that. Everyone okay with that? That's the standard CGAR holiday CGAR formula. It applies for all dehydration in children now, including DKA. Okay. So, and the reason we have these differences between adults and children is because of cerebral edema, which is the big killer in pediatric DKA. Nobody really knows how to predict those who are going to get cerebral edema, but it's probably to do with how sick they were to start with. People have tried restricting the fluids, but that doesn't seem to stop it happening. And then you end up losing children from under resuscitating them. So, if you look at the causes of death, inadequate resuscitation comes in if you don't give them enough fluids. You don't bring in insulin until 1 to 2 hours, and you start at 0.05 units per kg. If you do get cerebral edema, you give them high hypertonic saline. And those are the features of cerebral edema. Okay, can I move on from DKA? Is that all right if I go on from there? Okay, so antifreeze. As soon as you see something like a bottle of antifreeze, we're talking about, what's the, osmolar gap, aren't we? Osmolar gap, we're talking about ethylene glycol, aren't we? So what's his calculated osmolarity? We did that earlier for HHS. What would his be? Twice the sodium, yeah, is 282, plus his urea, or I'm going to call that 5, 287, plus his glucose 6, 293, yeah? So his calculated is 293, which is normal. But when they measured it in the lab, it wasn't 293, it was actually 328. What that tells you is there's something in his blood that's adding osmolar pressure, but that isn't in your electrolytes. Yeah, there's normally a gap of about 6, 7, 8, something like that. But with him, it's much bigger, it's 30. And that is one of the ways you can tell he's had ethylene glycol, because it does that. It gives you an osmolar gap. You only ever meet this in this exam in your life. You probably never do this ever, but that's how you would do it if you wanted to. Okay, so D is the answer. Osmolar gap is about 35. So, returning traveller, 39.5 fever. He's come back from Asia 7 days ago. And you're thinking, could it be malaria? Could it be dengue? Which would suggest that dengue fever is more likely? Rash. You don't get rash in malaria. Yeah, you don't get rash, don't get sore throat in malaria. But you can get any of the others in malaria or dengue. Rigors isn't so much a dengue features. So dengue, high fever, rash, muscle pain, the features of dengue. And then hemorrhage in some people. 34, frightening sensation of a tongue coming out. She's on metoclopramide. What's that called? Acute dystonia, yeah, also known as an oculogyric crisis if it affects the eyes. And the treatment is, so an anti-muscarinic agents, and the commonest one would be procyclidine, isn't it? So there's others as well, benzhexol, benztropine, but procyclidine. Okay, here's another ECG question. 47-year-old man, a bruising feeling in his central chest at 3 a.m. Now, obviously, you look at that ECG and you think, not happy with that ECG. He's got some ST changes, hasn't he? He's got some ST changes in 2, and probably AVF, and in V2, V3, V4, V5, V6, and it's concave upwards. So it's across the leads pretty well. And so what would you think with that?
Pericarditis.
Pericarditis, yeah, that's what I was leading you towards, pericarditis, yeah. Concave upwards, and often widespread in the ECG. 36, nice easy one. Blood gas, you're on the way to see the patient, and you look at these blood gases. Again, acidosis, look at the CO2 and the bicarb, and you can see it's a compensated type 2. And so only one that fits there is COPD. Yeah, everyone happy with that? Yeah. Easy one. 37. Oh, it's another head injury one. B, everyone happy? It's from the first list. By 2 hours, you've got to be above 15. You've got to be 15, haven't you? So that's okay. And why have I put this in? Okay, here's another little, here's the 8-hour list, the after loss of consciousness, but that doesn't, I'll skip on from that. We looked at that earlier. 6-year-old, moderate exacerbation of asthma. Follow-up plan. So if you read right to the bottom of the guidelines, it tells you what you should do at discharge, both for adults and for children. Adults, GP in 2 days. Children, it's also GP in 2 days, but it also recommends asthma clinic within a month, yeah. So that is actually, it's a bit of a mean question, but that's where it comes from. It's at the bottom of the BTS guidelines. And the point is that you have to get somebody, you know, just because the patient's well enough to go home today, you don't know how, you can't leave it, yeah? You've got to get them followed up reasonably soon. That's the point. You get a follow-up with a GP quickly, 2 days. I think it's a bit of a small print question, but there we are. Okay, 75-year-old man, lower abdo pain, less and less urine every day. He's on an ACE inhibitor and a diuretic for hypertension, and he's on insulin for long-standing diabetes. He's got a creatinine of 466, urea of 18, potassium of 7.1. That's quite sporting, isn't it? First action. Okay, so I think that's still, I'm slightly conscious that I can't justify why that rather than A, because a salbutamol nebulizer can also bring down your potassium, but that I think is usually still said to be cardioprotective, isn't it? Giving 10 mils of 10% calcium gluconate. I won't argue that one because I'm not sure I can give you chapter and verse for it. Okay, evidence-based medicine question. So you've got a new test which has got the same sensitivity as the old test, but it's got a slightly better specificity. Okay, so this is really a test of whether you understand the meaning of those two terms, sensitivity and specificity. So how would the new test change the performance? So the big thing, as I keep saying about specificity, is the lower the specificity, the more false positives. The more people you're telling them you might have that, you know, you might have prostate cancer or breast cancer or DVT or whatever, but they haven't. It's just that your test has got a low specificity. So the right answer is it's E, isn't it? So you would exclude more DVTs, slightly, not a lot, but a few more. 41. Burning feeling, and then he's got this rash.
Poner stick up altavoz.
Yeah, it's just a funny presentation of shingles, isn't it? Shingles in a funny place.
Un segundo.
Okay, and so most appropriate treatment. So it's only just happened.
Lo siento, no he podido reproducir eso en el altavoz que me has dicho.
Yeah, everyone happy? C, oral acyclovir. Right, okay. CSF question. Now, these are pretty rare to get this, but it is sort of in the curriculum, so probably worth just being aware of it. So, what should the white cell count in a normal person's CSF be? It could be 0 or less than 5 per millimeter cubed. Yeah, it's just really, there's very little in CSF, isn't there? So less than 5 cells. What about protein? If you think what your normal protein is, 60, 70 grams per liter. In the CSF, it should be less than 0.5, less than half a gram. And your glucose, what should your glucose be in your CSF? About 2/3 of your blood. So it's usual to take the blood sample at the same time and see if it's about 2/3. So what does disease do? What do bacteria do to those three? Well, they push your white cell counts up high, don't they? And often they'll give you a cell type. They'll tell you if it's neutrophils or lymphocytes. Bacterial meningitis, you'd expect neutrophils, wouldn't you? Viral, you'd expect lymphocytes. TB, you'd expect lymphocytes. What about protein? Any inflammatory process will put up your protein, anything. Glucose, bacteria eat it, don't they? They eat it up. So any bacterial, either TB or meningococcus, etc. So what does this sample tell you? So the glucose is not low, isn't it? So it can't be bacterial or TB. Yeah, but the cells are up, so there is meningitis, and it would be typical of a viral meningitis. Yeah, everyone okay with that? 43. Okay, so this is a little bit of a hard one. This is about preeclampsia. So people who have got blood pressure before 20 weeks, we call it chronic hypertension. But if it's after 20 weeks, it's gestational hypertension. If they get proteinuria, we call it preeclampsia. And if they then get symptoms, we call it severe preeclampsia, and we start worrying about them. Or if they get abnormal LFTs and FBC. So she's 26 weeks, she's got a high blood pressure, and she has proteinuria, and she's got a persistent headache. So she's got all of those, isn't she? She's at risk of eclampsia. So she will, I'm going to go for E because that's what the guideline, you know, you still have to be admitted first, but you want to stop her fitting. No, but you want to stop her fitting. So with that, so this is the guideline. Consider the need for magnesium if one or more of the following features of severe preeclampsia are present. Ongoing or recurring severe headaches, or any of the others there. So it's to prevent it, because if you get into eclampsia, the morbidity or mortality shoots up, both for the fetus and for the mother. Yeah. So you want to stop them fitting. So what's the, how much magnesium, anyone know? It's 4 as against 2 that we use IV for asthma or for torsade de pointe. Those are the 3 uses of magnesium, aren't they? Okay, 44, nosebleed question. Old man. He's had 1 bleed, stopped, now it's come back again, and steady since. Okay, right, so the anterior or posterior hemorrhage. If he's a young person, where's he likely to be bleeding from? Anterior, Little's area, yeah, the Kieselbach's plexus, isn't it? The 5 vessels that feed into the septum. If he's an old person, though, it might be anterior, but it's significant. About 50% of them are posterior, aren't they? Which is usually venous from the lateral wall, not from the septum. And so squeezing the nose won't help that. Squeezing the nose only helps anterior bleeds. So therefore, balloon tamponade is the answer. That's the answer I was looking for there. 86-year-old can't get out of the bath. Which of those would you consider?
Hypothyroidism.
D is the answer I'm looking for, frailty. So frailty is a syndrome, and just to touch on it, this is from the British Geriatric Society. We are encouraged to look out for it. In 5, there are 5, they're called the Big 5. And they all relate to underlying loss of reserve. You know, when you're young, you've got lots of reserve. Reserve cardiac, respiratory, brain, everything, muscle. But as you get frailer, and age does not mean you have frailty, but it gets commoner as you get older. Just because you're 90 doesn't mean you're frail. You may not have these things, but it goes with age. So, and how do you tell that people have lost their reserve? Well, they fall because they can't correct themselves. They haven't got the muscular strength. They can't get off the toilet or get out the bath, perhaps, immobility. The brain goes and they develop delirium, incontinence, or they're very more susceptible to side effects of drugs. Those are the Big 5 frailty syndromes. Question.
Well, actually, I think
But okay. But her low temperature is secondary to her being stuck in the bath, because she's naked in the bath, isn't she? For 3 hours, so she get a bit cold. But that's why the hypothyroidism was a trap.
He's more risk for.
Okay.
paralysis
Anyway, but that question was just an opportunity to bring in the concept of frailty. So just remember falls, you know, immobility, which is really can't get out the bath. Can't get out of the bath has got a 50% mortality. It's really serious being stuck in the bath. It's not a trivial problem. People die from it. So falls, immobility, incontinence, delirium, and side effect susceptibility. Good. Okay, so that's question paper 4 done. So Karen, I think we're going to go straight to paper 5, aren't we? Oh. Karen, tell me. Oh, yes. You've already done paper 5, haven't you? You've done paper 5. Okay. Shall we give, what time was lunch break due to be? 12:30. Shall we give people just a tiny bit longer lunch so you can fill in any question 5 things you haven't done? Should we do that? Should we say come back from lunch at 1:15? Yeah. Should we do that, Karen? Does that work? Okay, so everyone at home, come back from lunch at 1:15 and try and make sure you're up to speed with paper 5, and then we'll have a discussion about paper 6. I'm hoping you've all done 5 and 6, so that we don't need to create time to do them. Okay, so come back at 1:15. Okay. This is where I need a spoon to ting the glass. All right, we all good to go? Paper 5. People at home, can you hear me?
Yeah.
Good. Okay, paper 5. Homeless man, alcoholic, collapsed on the street. And here's his ABGs. So you start with pH, he's acidotic. You look at CO2 and bicarbonate. CO2, well, it's about normal, upper end of normal, and bicarbonate is low, so he's got a metabolic acidosis. So we could do the anion gap, couldn't we? Have we got enough to do the anion gap? We could add his sodium and potassium together and subtract his bicarbonate and chloride. And it's about 35, isn't it? Is that anion gap? The different formulae, whether you put the potassium in or not, but I think it comes to about 35. So he's got an increased anion gap metabolic acidosis, which takes you into your cat mud piles if you use that particular mnemonic. But most anion gaps are, metabolic acidosis are increased anion gap. The other ones, the normal anion gap ones, are quite rare. So anyway, what do you think? Because actually doing that calculation doesn't help you. In fact, it's ketones, isn't it? And it's probably alcoholic ketoacidosis, which is a phenomenon that happens with some alcoholics who've got quite poor livers, and particularly if they've not been eating. They've been drinking and then vomiting and they haven't been eating. And so they go into ketone production and they become ketoacidotic. And so anyway, there's a bit of text about it, but we won't stop and dwell on that. The point is alcoholic and a metabolic acidosis. Okay, and so the next question is a sedation question to do with discharge. So it's 32-year-old man, shoulder dislocation has been done, and they want the cubicle. Just by the by, after you've done a reduction, you should keep people at the same level, shouldn't you, of supervision as they had for the reduction. So as soon as it's done, they should stay, usually in resus, isn't it? They should stay there, and that should be where they continue to be observed. But which of these answers, what does the college guideline say? Yeah, when vital signs are normal and pain is being controlled. And this comes from this document, which is quite old now, 2012, which is between the College of Anaesthetists, that's them, and our college. I just want to bring out a couple of other things about sedation from that document. First of all, definitions of sedation. So just be aware of the difference between these two, moderate and deep sedation. So moderate sedation, patient responds purposefully to verbal commands. You know, David, the patient responds. Yeah, he's with you. But this one, deep sedation, responds purposefully following repeated or painful stimulation. Yeah, David, pressing on the eyebrows, whatever. You have it's hard. So that's the distinction. And of course, these are not, this is a gray range, isn't it? It's not a black and white distinction, it's a range. And one of the worries is, of course, that there is a continuum here, and the continuum then runs to general anesthesia. But they're just drawing out that distinction. So there are some guidelines about where you do it and what staffing you need, depending upon the depth of sedation you're going to use. So first of all, if you're just going to give Entonox, you just need one practitioner, and you can do it anywhere. Yeah, so you can do Entonox anywhere, which is probably what we're used to. And the only observation, well, maybe a pulse ox. But once you get to anything beyond that, so moderate or deep, or of course GA, then you have to do it in resus, and you have to have at least 3, ideally 4 levels of monitoring: ECG, BP, SATs, and capnography, and 3 staff: sedationist, operator, and nurse. Someone there just to sort of back you up and provide things, etc. Okay, and then it also has recommendations about certification. And that applies from that point onwards. What about fasting? Well, the standard fasting requirements are that you don't need anything for Entonox, for minimal sedation. But once you get to moderate sedation, then it's the standard guidelines: 2 hours for clear fluid, 6 hours for solid food. This is under some discussion. It's controversial because it may be that that's too restrictive and it might delay something being done which could be safely done. But that's the current guidance. And then there's also guidance, which we might come to later, about when are they ready to go home, which we've already touched on, when their vital signs are normal and pain is controlled. And there's a few other things about when they go home. They shouldn't be behind a locked door for 12 hours, shouldn't drive a car, make any important decisions. Does that ring a bell? Various things you shouldn't do after sedation. Okay, number 3, 24-year-old presented and her boyfriend says that she went stiff and then fell over, making odd noises. Never happened before. She's a carer driving from client to client and asks, can I carry on driving? What would you say to her? Yeah, she must stop driving immediately and inform the DVLA. Okay, I'm going to come to the DVLA guidance in a moment, but just a couple of things from the epilepsy. Just scanning this to see if there's anything really worth. So, yeah, so what tests do you do if somebody comes in with a first seizure? That sometimes comes as a question. So we normally, for women, we do a pregnancy test if they're reproductive age. We do an ECG, and we measure electrolytes, including calcium and sugar. Those are the usual things. It says here, don't measure the prolactin. Why? Why would you ever want to measure prolactin? What's the background to that? It's to do with seizures push up your prolactin. So if you've had what used to be called a pseudo seizure, but now is called a non-epileptic attack disorder, you don't. Your prolactin doesn't go up, but it's not totally reliable, and so we're being discouraged from doing it. But that's the background to prolactin. Okay, and then yeah, that's fine. So what about the DVLA guidance? So we're just going to touch on a couple of things from the DVLA. This is the Assessing Fitness to Drive document, which is for medical professionals. And it's quite a big document with many sections. So there's a number of health things that could affect your driving, from psychiatric conditions to cardiac conditions, even severe respiratory ones, etc. And right through this document, it has 2 columns. One is for normal car drivers, and the other is for bus and lorry drivers. Generally speaking, the restrictions for bus and lorry drivers are orders of magnitude harder, 2, 3, 4, 5 times as harsh. Yeah. So, for example, when it comes to a first seizure, which is here, driving will be prohibited for 6 months, unless it's unless there's an underlying cause. So, generally speaking, you can't drive for 6 months for cars, but for lorries, 5 years. Yeah, lorries and buses, so much more restrictive. A few other ones. What about strokes? 1 month for cars, 1 year for lorry and bus. Acute coronary syndrome, just had a heart attack, can't drive your car for a week. Or 6 weeks, I think it is, for a lorry or a bus. But you've also got to have a minimum cardiac function to drive a bus or a lorry. You've got to have at least an ejection fraction of 40%, for example. So just to be aware of that, we might meet that again when it comes to dementia, which is another one that comes up sometimes. Okay, here's a girl with vomiting and diarrhea, 3-year-old, sleepy, reduced skin turgor. So this is the the D&V guidance. Which is it? So she's got evidence of dehydration, reduced skin turgor, dry mucous membranes, not tolerated oral fluids for late hours, you're told by the parents. But still, our first step is oral fluid challenge, isn't it? With oral rehydration solution, ORS. Yeah, well, you'd still try it, wouldn't you, with oral rehydration solution? Even if somebody is vomiting, we know that giving oral rehydration, the whole thing about having the sodium, 60 millimolar sodium, it's very rapidly absorbed. And so it's much better than water. And just giving ORS, even if somebody's vomited, you give them ORS, they might vomit again half an hour, but a lot of it may well have absorbed in the interval. That's the great thing about ORS.
And just on that, wouldn't water be a better choice because it would less be?
No, because water will not absorb as fast as ORS. That's the whole point about oral rehydration solution. Yeah, it's speed of absorption.
Isn't the reduced skin turgor indicated on the red?
That relates to this thing here. You can't, I know you can't read that, but this is from the NICE guidelines. I just want to tell you basically what it says. There was a time when we were all trained to calculate percentage dehydration by looking at the mouth and the skin turgor and making a judgment. But we know that when that was actually put to the test, because you know whether you're right or not, because you weigh the child after recovery, because all that weight gain is water, and you see if you're right or not. We know that we never were. We're always wrong. So now we don't do that anymore. Instead, we just talk about dehydration and shock. If they're dehydrated, we say they're 5%. If they're shocked, we say they're 10%. And that's basically all it is. So these are the features of dehydration. But wherever there's an asterisk, that means it's a high risk. You're more concerned. But it doesn't, you still go with oral first. You still go with oral rehydration and bring in IV if oral rehydration fails. Okay, so that's how it works. Any questions on that before we move on? Okay. 6-month-old, coryzal illness recently, and now rapid breathing, struggling to feed with mild recession. Respiratory rate of 65. It's pretty fast, isn't it? Pulse 150. SATs 95%. Likely diagnosis? Bronchiolitis, absolutely. So just a few things about bronchiolitis. It's one of the few viral diseases that affects very young babies, where maternal immunity doesn't seem to protect. It's very, very common, and only a minority of RSV infections lead to bronchiolitis. But they don't get, for some reason, it's one of those things that maternal antibodies don't help you. The main diagnostic features, of course, are bubbliness, crepitations in the chest, tachypnea, and increased work of breathing, so recession. And it's linked to later going on to having viral-induced wheeze. Okay, so those are the diagnostic features. Higher risk if you're very young or premature. And the criteria for admission, so if there are episodes of apnea, SATs less than 92%, this is an important one. Not feeding, struggles to feed, so breathless, can't get the bottle down. Maybe just gets 1/3 of the normal bottle, admit. Manages, well, 2/3 of the normal bottle, might be able to go home. You see what I mean? So it works on whether how well they're managing to feed. One of the issues with bronchiolitis is it's a long illness. If any of you have had a child with bronchiolitis, it goes on 3 weeks maybe. So it's a very stressful illness for parents. You know, you've got this breathless child who's struggling to feed, and it just goes on day after day. And so it's very taxing, and you need a fairly good social setup to cope with it, which is why some people will, particularly in the worst phase, may need to have admission for support. Of course, we've got no interventions that specifically help apart from oxygen, suction, you know, nasogastric feeding maybe. Okay, bronchiolitis. Moving on to otitis media. 3-year-old, few hours, temperature, look at the ears, and there's the left, there's the right. What should you do? Who gets antibiotics for otitis media now? In the past, it used to be every child. Every red ear got antibiotics. But again, part of antibiotic stewardship, they've tightened it right down. Perforation. So perforation, if you've got otorrhea, pus coming out the ear, yes. Bilateral in under 2s, yeah. And then only 2 others. If you're ill, really ill with it, you know, septic with it, or underlying vulnerability, like, you know, cystic fibrosis or something that makes you more vulnerable. But otherwise, no antibiotics. But what you can do is what's called a delayed prescription. You can say, you know, these days we don't treat this with antibiotics, Mrs. Jones, but what you can do is I'm going to give you a prescription. And then on Monday, if he's not better, go and get the antibiotics. But I think he will be. You know what I mean? You have that sort of discussion and you try and avoid antibiotics because it only shortens the illness by half a day or something, doesn't it? Okay, so that's the right answer. These are the criteria. Antibiotics, otorrhea, that's perforation basically, under 2 with both ears infected, or systemically very unwell, so not just a temperature, not just a bit out of sorts, or have high risk complications. It doesn't say there, but it is also people who are vulnerable. Backup, and then backup prescription here if it doesn't get better within 3 days. Okay, is that all right? Question on.
There is an option to say provide delay antibiotic prescription with estimation. So is that not fit into that?
Oh, in that question?
Yeah. Rather than no antibiotic. It covers both.
Yeah, well, the right advice is no antibiotics are needed.
Yeah.
The delayed prescription is the sort of, it's an option. It's an option you have, but the primary thrust of this guidance is no antibiotics. And it shouldn't be routine to provide a delayed prescription. Sorry? Yeah, I don't think it is. It's not supposed to be. Okay, anyway, we've gone over some of the stuff you need to know on it. Here we go. 7. 5 hours of chest pain. He's been given aspirin. Got a little bit of a lowish blood pressure. Here's his ECG. Okay, ECG, what are you going to say about that? Well, he's got slightly iffy T waves, doesn't he? V2, V3, V4, bit of ST depression, V5, V6. 1, 2, 3. But he's not got a STEMI, has he?
No.
But he's got chest pain and an abnormal ECG, so it's a non-STEMI. Yeah, everyone happy with that? N-STEMI. So how are you going to handle his N-STEMI? Remember that NSTEMI chart? Start with aspirin. We've already had that, haven't we? And a antithrombin. Antithrombin, and there's a choice of options there, fondaparinux or low molecular weight heparin or heparin. But fondaparinux would be the first choice, generally speaking. They're called antithrombins. That's because they act on antithrombin 3. Remember? We'll come to the clotting chart in a minute, but clotting all pivots around factor 10. It's all about 10 to 10A, activation of 10 to 10A. And heparin and all of those drugs, they don't do anything on their own. They only work by binding to antithrombin 3, which prevents activation of factor 10. So that's where they all work. And that's why they're called antithrombins. Okay. Oh, here it is. Yeah, so we were up there. Then once you've done that, you then come into your GRACE scoring, don't you? So I think we've covered that. Offer aspirin, fondaparinux, and then some alternatives for renal impairment, for example, and then do a risk assessment. You don't need to know what's in a GRACE score, but those are the bits that are. It's quite a big score, a lot of stuff to go into it. So it's got the age, the heart rate, blood pressure, that's creatinine, Killip class, that's the heart failure, evidence of heart failure. Have they had a cardiac arrest? Have they got elevated cardiac markers and abnormal ECG? All of these give scores, and it all gets added up. You always do it on a calculator, you know, some sort of online calculator. And then based on that, depending on the score, low risk, intermediate and high, and then usually low risk, conservative management, intermediate or high, you're going to be thinking about angiography and proceed to what as required. Okay, stenting, etc. So that's the approach to non-STEMIs, risk assessment, and that divides those who need treatment or not. Question 8, 7-year-old, facial rash, 2 days, it's gradually spreading, not painful, and he's well. This is, again, it's got a nice guideline for this, which changed the standard treatment. What's wrong with him? Impetigo, honey-crusted lesions, yeah, caused by staphylococcus, usually can be strep, in fact. And the treatment used to be topical fusidic acid, but it's now hydrogen peroxide. Yeah, well done, good. And unless they're systemically ill, when you would give them Fluclox, oral Fluclox, yeah. So this is the guideline, and there you have it. And fusidic acid is still there as a backup, and there's also mupirocin, yeah. Remember, if you come across mupirocin, it's used to treat nasal carriage, if you're an MRSA carrier, something like that, mupirocin. Question 9. Okay, 24-year-old, 3 days, nausea, constant pain in the right iliac fossa. She's got a temperature of 38.3, so quite a temperature. Pulse 105, tender in the right iliac fossa. Pregnancy test is negative. Best management step. Yes, it's a diagnostic uncertainty question, isn't it? Pelvic pain in females, is it gynae? Is it surgical? Is it urological? Yeah. And she's sick, isn't she? She's got a temperature, 38.3. So maybe that's an opportunity to talk about the admission criteria for PID. When do you admit someone with PID? If they're ill, high fever. If they're pregnant, if you're actually not that sure, diagnostic uncertainty, and also if they've got a tubo-ovarian abscess, you know, so they've got a big, you know. Okay. Related question, 22-year-old, lower abdo pain, adnexal tenderness and a mild fever. Pregnancy test negative. You decide it's PID, what you're going to treat her with. Yep, so you have to do triple therapy, don't you? There are some shortcuts, which we rarely use, like using ofloxacin and things, but we normally go for ceftriaxone, doxycycline, and metronidazole, don't we? So IM dose of ceftriaxone. Now, it says a gram there. I've got a moment of hesitation about whether it should be half a gram. I'm just slightly hesitant as to whether I'm confident it should be a gram or half a gram. And then doxycycline and metronidazole. Let's have a look at, so there are 3 BASH guidelines. Are people familiar with BASH? British Association for Sexual Health and HIV. And it's got guidelines for genital ulcers, for urethral discharge, and also for sexual history taking, which all can be useful to us. So, oh, here we go. This is PID. So if they're ill, give them IV antibiotics, or if they've got signs of an abscess, and then admit for parenteral therapy if severe disease, if a surgical emergency can't be excluded, if no response to oral therapy, abscess or pregnant. And here's the outpatient regimes. So this is the one, yeah, it is 1 gram. So 1 gram of IV ceftriaxone. If you were treating somebody if you had to treat somebody and you thought they might have gonococcus, what would you treat them with? Ceftriaxone and what? Azithromycin, yeah, because there is a very occasional resistance to ceftriaxone, and the azithromycin is designed to to knock them off and prevent the spread of resistant organisms. Okay, elderly couple, hit a tree, wife was driving, she's got a degree of dementia, husband is an alcoholic, they live remotely and they rely on driving. So what would you say about the driving? You've got an alcoholic and a dementia person. So can you ever drive with dementia? Yes, you can. And there's some rules and you need annual checks, but yes, you can. Can you drink if you are an active alcoholic? No, you can't. You have to be in abstention. And so B is the right answer. And again, if we go back to the same thing here and look at those 2 things, for dementia, you can't drive a bus, which is, of course, good news for everyone, or a lorry. But you can drive a car as long as you, there's some rules about it. There are some rules about it, but which we don't need to know about. But you have to be regularly assessed and so on. But you would normally just get an annual license, I think. Does it say that? Yeah. Okay. Annual review. Yeah. Okay. And then for the alcoholic, it isn't. Sorry, I thought it's probably earlier on in the earlier thing. For alcoholics, they've got to have evidence of abstention for at least a year for driving. You've got to have a... I'm just wondering whether to go back to that. I just don't want to... No, we haven't got it here. There are some quite strict criteria, and certainly if you've got biochemical evidence, but I think it's more than that. I think there's also, if your doctor suspects you are an alcoholic, I think there is a way you, I think there is a clause under that. but I can't remember how you prove your, you know, but that's more than we need to know, isn't it? Yeah. Yeah, yeah, it is interesting, isn't it? But okay, question 12. Head injury. Reduced consciousness needs to ask you to pre-oxygenate the patient. How would you? He's still breathing spontaneously. Yeah, so what's pre-oxygenation all about? What's the objective of pre-oxygenation? Yeah, to replace the nitrogen with oxygen, because then even if someone doesn't breathe at all, they don't ventilate, they've got a store of oxygen, which in a normal person will last them up to 8 minutes. Yeah, a long time. Yeah, and so that's the point. And to do it, to pre-oxygenate, if it's someone's breathing, you just put a mask on for 3 minutes with high flow oxygen. If they're not breathing, you minimum of 8, well, I think 8 breaths is the number they give, 8 full good breaths with a bag valve mask on high flow oxygen. Yeah, and you know, for a healthy person, these are minutes, 3, 4, 5, 6, 7, 8. This is the fall in saturation. So the people who desaturate faster are obesity, pregnancy, children, and sick people. Okay, child, 4-year-old who's trauma. Yeah, so this is a wet flag calculation, basically. So 4-year-olds, how would you calculate the weight? There's the current formula. Let's just go through it. How would you calculate an under 1, an 8-month-old? Half the months plus 4, yeah? So if they haven't got any years, you take the months, halve them, add 4. So half of 8 is 4, plus 4, 8. Yeah, that's how you do under 1s. What about from 1 to 6? Yeah, this is the, you know, this formula came in a few years ago now, but it does replace an older formula. So you double the age plus 8. What about over 6? 3 times the age plus 7. Yeah. So a 7-year-old would be 3 7s is 21 plus 7, 28 kgs. Okay. So this is a 4-year-old. So we double that and 8, and that gives us 16 kgs, doesn't it? So and then fluids, 10 mils per kg would be that. So in a trauma, you'd use the 10 mil per kg formula. And what's the formula for the ET tube? Yeah, it's that one hasn't changed. Age over 4 plus 4. Yeah, so at 0, it's 4 millimeters. At 2 years, that's half, which makes it 4.5. At 4 years, it's 5 millimeter. Yeah, 8 years, 6. 12 years, 7, 16 years, up to full 8, full adult male size. Okay. Oh, here they are. Sorry. And so wet flags comes in more to the OSCE exam. Then they expect you to be able to write out your, but just to be aware of these, we've done weight. This is ET tube, age over 4 plus 4. Fluids, septic 20 mils, trauma 10 mils, and also for diabetics, razepam 0.1, 0.1, and then glucose 2 mils, 10% per kg if you have a hypoglycemic child. 6-month-old, vomiting, abdo pain. Seems to be intermittent. Here's his abdo x-ray. What describes his radiological abnormality? Yeah, yeah. So C. And what do you think the most likely cause in a 6-month-old is? Intussusception, yeah. So just a little list there of causes of acute abdominal pain in children. We've touched on quite a lot of these. You need to know just a few facts about Henoch-Schönlein purpura. A few facts to know about that are it's a rash, isn't it? Primarily, often around the ankles, knees, and buttocks. It's associated with what happens to your kidneys. They have an IgA nephropathy, don't they? Usually goes away, but a few of them go on to get kidney problems. And they often have abdominal pain as well, don't they? But it goes away on its own. Okay, pyloric stenosis, we've talked about that. Projectile vomiting in a young male child, usually. And we diagnose it by palpating the olive, yeah, the thickened pylorus. And ultrasound can help, as shown here. Here's the thickened pylorus. Intussusception tends to occur about 9 months of age, typically, or around that. You know, invagination of the gut, red currant jelly stools. Yeah, I'm sure this is all familiar stuff. You diagnose it on ultrasound and you can treat it with a barium enema. So here, this is the ultrasound appearance. Looks like a target where you've got one loop of bowel inside another. And here's the barium enema appearance, and here's the loop inside the rest. And so, of course, once that's found, here's the anus is down here. They just increase the pressure of the barium enema and try and push it out. And it's quite successful, I think, about 80%, something like that. It's quite a successful intervention. I won't talk about appendicitis. We mentioned it yesterday. It's often atypical in presentation. So I'm going to skip off from that. Just a word or two on hernias. Hernias are more common, of course, in pediatrics. This is pediatric hernias. They're congenital, usually arise in boys, particularly prems. And if you've got an inguinal hernia in a baby, it will probably obstruct if it's not dealt with. So it's usually dealt with in the first year. Okay, 15. Fascia iliaca block. Shortly after the procedure, she became agitated, lost consciousness, and went into cardiac arrest. Additional treatment. Intralipid. What does it do? Just quick question. It's worth knowing this because it's useful sort of general knowledge. Did you ever spin your blood in medical school? Did you ever take your blood and centrifuge it and have a look at it and look at your plasma and your cells? And was there a little bit in between, which is the fatty bit, the lipids, yeah? And you hoped you weren't the one in the class with a big wide band of lipids, yeah? Did that not happen to anyone else? Anyway, the point about intralipid is if you give someone intralipid, it makes that bit much bigger. So you get this big lipid compartment in your blood. And then fat-soluble drugs will go into that. They'll compartmentalize into the lipid and leave the aqueous. They only are active in the aqueous compartment. In the lipid compartment, they don't do anything to you. So any lipid-soluble toxic drug, give them intralipid, and it will go into the lipid and not do them any harm. So it works for all the local anesthetics, verapamil, whole load of other drugs as well. So it's a very useful thing. It's getting increasing usage as a sort of general way of treating some toxicology problems, and this is its use for local anesthetics. So you need to just be aware of the standards. Yeah, everyone familiar with the limits? How much lignocaine can you give? 3 mils, 3 milligrams per kilogram with adrenaline 7. Yeah, everyone okay with that? Prilocaine. When do we use prilocaine? Beer's block, and that's 6 milligrams per kg. And bupivacaine, when do we use that? For blocks, yeah. And so this is cardiotoxic. So are these, but this is in particularly, and this is less cardiotoxic. So this bupivacaine and lignocaine doses are the same, and lignocaine with adrenaline and prilocaine doses are pretty much the same. And that's what intralipid looks like. What's intralipid usually used for? It's nutrition, isn't it? It's part of total parenteral nutrition. It's how you give people fat if they haven't got a working gut. 70-year-old, sore throat, noisy breathing. So she's elderly, she's got a sore throat, noisy breathing, she's ill, and she has stridor. Sore throat a few days ago, much worse today. I think it's got to be C, hasn't it? Retropharyngeal abscess is usually a pediatric problem. So the lymph nodes behind the pharynx that suppurate, but it can occur at an older age. Obviously, if it had had epiglottitis there, you'd have probably gone for that. Epiglottitis used to be a pediatric problem from Haemophilus, but that's now quite rare, and it's now more of an adult problem from pneumococcus or something, some other bug. 17. 19-year-old student brought in by staff thinking he may have a mental illness, increasingly withdrawn and stays in his room for days at a time. Which of the following would most strongly suggest a diagnosis of schizophrenia? E, yeah. Thought insertion. A 74-year-old woman, known end-stage metastatic breast cancer, arrives in ED. She's approaching the last hours of her life. Respiratory secretions are being, she's very bubbly, a bit unpleasant. It's just one of those little facts just to squirrel away. That is the right answer. And where does that come from? It comes from here. Managing noisy secretions. So this comes from the NICE guidelines for dying adults in the last days of life. Consider a trial of medicine to treat noisy respiratory secretions if they're causing distress. Atropine or glycopyrronium. Okay, that's where it comes from. Or hyoscine. Okay, 19. Undertaking a Medline search, you find a range of different articles. Which studies will generally give the most reliable evidence? I'm not hearing many voices. No, it's actually unblinded clinical trials. So blind RCTs, randomized controlled trials with blinding, are the best, but not all things can be blinded. Yeah, some things you just can't, like putting someone on a ventilator or not. You can't blind people to that, you know, for example. And there are many other things which you can't really blind people to. But there still can be well-designed studies. Yeah, and then you come down from that to observational studies, studies where you compare things which have happened naturally, like case control and cohort studies, where you have natural experiments. These people had this, here's a matched group of people who didn't, let's follow them up. Or these people have this disease, these people don't, let's look backwards and see if one group had more of an exposure than the others. Those are your cohort and your case control studies. And at the bottom of the pile, of course, is expert opinion. Not that expert opinion is poor, but it's just not sort of as, because it can easily change if some better evidence comes along, because we might all just be doing the same as we've always done. Okay. Cluster headaches. Which of those is most likely to help him? Yeah, everyone familiar with that? High flow oxygen works quite well for cluster headaches. So let's talk about, so cluster headaches, who gets those? Men, late middle age, men. What's the sort of pattern to it? It's in clusters. Yes, exactly. It occurs. It's called cluster because you get it every day for 3 weeks or 2 weeks or something. That's your cluster. Where do you get it? Often around the eye, yeah, and it's associated with Lots of sort of autonomic things, isn't it? So lacrimation, runny nose, edema, small pupil, yeah, number of autonomic things. Is it a bit nasty? It's said to be one of the most awful things, head banging pain. You know, people will, you know, trying to distract themselves from pain. It's very, very severe. And it can be treated either with oxygen or with triptan, sumatriptan, yeah, treatments. Okay, 21. Right. Oh, it's a hypoglycemia. So it's a 42-year-old collapsed. We don't really know why, but he's hypoglycemic. Best initial treatment. Well, we used to use that 50%, 50 mils, 50%, but it's like syrup. Have you? Do any of you use it still? It's painful. It's bad for your veins. So hyperosmolar, etc. So we don't use that so much anymore. We now, for adults, would use 20%, wouldn't we? Isn't that what you use? 20 mils, 20%. Oh, sorry, 100 mils, 20%. And of course, in children, you'd use 10%. 22, young lad, come off his bike after doing a wheelie or something, and he's he can't weight bear, and he's got a swollen knee. Is that you? Yeah, that's the right answer. D. So your anterior and posterior cruciates both attach onto the tibial spines there, and you can, in you know, if there's a traction force on the knee, pull off the tibial spines and increase the joint space here. And so that's what he's got. 23. 78-year-old woman, sudden onset, abdo pain and nausea. Abdomen is soft, despite her pain, it's quite soft, but she looks sick. She's got a lactate of 3.4. What is that telling you? Yeah, so lactate means anaerobic metabolism, doesn't it? And so this is a classic embolization, yeah, SMA embolus probably. Okay, again, another sort of classic 28-year-old man, chest pain and breathlessness. He looks cyanosed and his blood looks chocolatey. And you think he's got methemoglobinemia, and what's the treatment? Yeah, methylene blue. All right, yeah. So the point is, yes, so one of the features of embolization is the pain is out of proportion to the signs, at least early on. They don't get much peritonism early on, so that you feel the tummy and, well, it's a bit sore, but not very, but the patient's clearly quite ill because they've got this dent. Okay, 25. Okay, it's an easy one. Closing the wound, we've already seen this knee actually. Closing the wound with, yeah, adhesive strips. 26. Ankle injury sustained during a football game. This is a Salter-Harris question, isn't it? Salter-Harris 1 to 4. So, and the right answer is a, it's a 3, isn't it? Salter-Harris 3. Just quick run through that. So if you have a strain, a stress on a joint in a child where you've got epiphyses, they are a point of weakness. If you just strain the epiphysis without breaking any bone, you get soft tissue swelling around it, and that's a 1. So it may still be significant, but it's a 1. The next grade up is you get a strain through the epiphysis, but it breaks off the thin metaphysis. Yeah, and it usually takes off just a little triangle on one side. That's a 2. This one is a much more unusual 3, where you've broken the epiphysis. And if you have both of those, metaphysis and epiphysis, it's a 4. Good, okay. A child trauma, fallen from a balcony, despite 3 attempts at cannulation, unsuccessful. Okay, so you mustn't go distal to an injury, do you? So you don't go to any vein distal to an injury. And the next, we used to talk a lot about tibial intraosseous, but there's been a bit of a move anyway towards humeral head rather than proximal tibia. But certainly you wouldn't use proximal tibia if you have femoral fractures. So humeral head is the location. Okay, so pretty serious clashed heads in a football game. A couple of lads from your academy. This again is a young man I saw a while ago, hit the heads hard, and he's got a pretty bad headache. And you get his CT back and you think, grief. Okay, I wonder if he's got raised intracranial pressure because he's young, so he's got a tight brain. There isn't a lot of room. What are the features of, what's the earliest feature of rising AC intracranial pressure? It's A, isn't it? Impaired cognitive function is the earliest feature.
What's the latest?
So, well, you only get the palsy. So you can get 3rd or 6th nerve. This is 6th nerve, isn't it? It's said that the 6th nerve. This is really, you really get 6th nerve palsies in chronic raised ICP. It's thought that it has a long intracranial course, which means it's exposed. 3rd nerve is because of shift. So you've got to get shift. Once you've got 3rd nerve palsy, so you've got a big pupil, down and out pupil, then you're in trouble because that means you've got shift, isn't it? That's here. Number is D, isn't it?
It is more prominent in coning of the when pressure rate and coning of the brain because 3rd nerve.
So 3rd nerve palsy, it gets pressed against the tentorium.
Yeah.
So it's movement. It's sideways movement of the brain. Slow pulse and rising blood pressure. This is a late phase. This is a coning phenomenon, irregular respiration. Slow pulse, I can't tell you when that comes in, but it's a sign of quite significant raised ICP. You get slow pulse and high blood pressure. Okay, 29, back pain. He's got a new numbness, chronic low back pain. He had a slip disc a year ago. Which of the following would worry you most of all? Yeah, everyone happy with that? E, yeah, because that would mean he's got a cauda equina. Any of the others could just be a standard slip, slip disc, couldn't they? Disc prolapse. A 64-year-old man with a dissecting aortic aneurysm. Aortogram confirms it begins at the abdominal aorta and spreads to the bifurcation. BP is 173 on 84. Which of these treatments most appropriate? May not be what you would reach for, but which would be most appropriate? Yeah, it's to bring his blood pressure on down, isn't it? You're going to want to get his blood pressure right down, systolic below about 120, aren't you? Yeah, so, and that's going to be the most, a safer way of doing that than the nitrates. 31. So this is an HIV exposure question. She's been spat on. She's a police officer and she's got been spat on, but she doesn't know. She just knows he's an IV drug abuser. So he might have HIV. What are you going to do next? Yeah, you'd ask. Yeah, you'd find out whether the source is HIV positive, wouldn't you? But the patient will have to give consent. You know, the shoplifter. Okay, just a little bit on that. So one of the things we often ask with a needle stick injury is, details of the actual procedure by which the needle stick happened, don't we? So was the needle visibly contaminated? Was there blood in the syringe? Did it go through a glove? All those sorts of things. So these are the things that are known to put you at higher risk from a needle stick injury with HIV. And as you all know, I'm sure that it's about a 3 in 1,000 risk based on some data that's quite old now. But in fact, the exposure to bodily fluids, through mucous membranes is much lower. It might even be 0, but it's certainly a lot lower. It might even be 0 now. But it's usually thought of as about 1 in 1,000, 0.1%. And this is just for interest's sake only. Health Protection Agency says that in those years, no new cases after 9,000 reported occupational exposures to needle sticks. So very whatever the way, whether it's PEP or whatever it is, there's much less of it happening. Maybe people's viral loads are much lower as well. Okay, 32. So this knee, she's got pain in the knee for 6 weeks. Okay, it's one of the spot diagnoses, just in case you see it. Erythema ab igne, yeah, heat, just a hot water bottle over a sore knee. Livido reticularis, which is venous inflammation, which is quite rare, does look a bit like that sort of pattern, and it's a feature of some collagen vascular diseases like SLE, but it's quite rare. Okay. 33, 12-year-old, fever and cough, and he's got those. What other feature likely to be present? So what are those? What's that tell you? Fever and cough, and those he's got measles. Those are Koplik spots. So he's got measles, and the Koplik spots usually comes how long before the rash? 1 day. The day before the rash normally. Where does the rash start? Yeah, so usually around the hairline, something like that, in the face, isn't it? And then spreads downwards, maculopapular rash. So what precedes the Koplik? What comes before Koplik? It's the prodrome, isn't it? What's the prodrome like in measles? Yeah, red eyes, temperature, miserable. Coughing, maybe miserable looking sort of child. And so the answer to this one is, yeah, you're looking for the prodrome features. That's the point there. Was there a question? Okay. 2-year-old. Oh, while we're on this, what about infectivity of measles? So when will this child, so if this has happened today, got Koplik today, what's the infectious period for this particular child? This is the WHO figures. Not the prodrome, it comes from the appearance of the rash. It's done from the first day of the rash, 4 days back and 4 days forward. So in other words, this is already 1 day back. So go back 3 days from today, any contact is that there's a risk. And go forward 4 days from tomorrow, any contact, there would be a risk. So that's the way it's usually traditionally calculated. 34, 2-year-old, midnight barking cough. He's got a bit of a temperature, respiratory rate's up, saturation's okay, initial treatment. Yeah, oral dexamethasone, I'm happy with that. And if he was really, really sick, what else could you use? Nebulized adrenaline, yeah. Which you can work it out by weight, but 5 mils of the high strength, isn't it? 5 mils of 1 in 1,000 in a nebulizer. Dose isn't that important because most of it ends up just in the room anyway. Right. So here's the treatment. Single dose of oral dexamethasone. You've got another alternative. You can do inhaled budesonide or IM dexamethasone. So reasons for admission include underlying susceptibility, heart and lung disease, or factors, not taking fluids, etc. Or somewhere it should say high severity. Okay, 35. Man's come in with diarrhea, no pain. On an abdo examination, a pulsatile mass was noted and a contrast CT looks like this. But he's quite stable and he's well enough for discharge. So what have you found? What does that CT show? Yeah, he's got an aneurysm, isn't he? And of course, that's not that uncommon, which is why we now screen for it to find undiagnosed AAAs. And I think the positivity rate is somewhere between 1% and 2%, isn't it, in the screening program? So there's quite a few of them around. What are you going to do with the 4.7 centimeter aneurysm? Monitoring. What's the sort of magic number when they say 5.5? Yeah, is the. Okay, and where does that come from? It comes from here. So if it's symptomatic, well, then you would need to get it repaired. But if it's not, if it's either growing fast or it's more than 5.5. So of course we don't tend to know that, but if it's asymptomatic more than 5.5, that's indication for surgery. Okay, 36, button batteries. It's that age of foreign body swallowing, etc. And he's swallowed a button battery. So how quickly can a well-charged button battery cause mucosal damage? Well, 2 hours is the sort of given figure. So quite quickly you can get mucosal damage. So you can't hang about with them. So the right answer is, yeah, C. While we're talking about foreign body ingestion, there's been a little bit of talk recently. There was a death recently, a few weeks ago, from magnets, fridge magnets. Just be aware of that. Another thing, one fridge magnet is okay. It's two that's a problem, isn't it? Because you get them in exactly as you say, two adjacent loops, and they stick together, and you've got obstruction from two magnets. Okay, 7-year-old, fever and rash. Okay, so we're back into, so what's this rash? Yeah, so it's maculopapular. You can't tell it's papular, but it looks like it might be, and it's confluent. It's a measles rash, morbilliform rash. But he was at a party 3 days ago. The rash started yesterday, so it's the same question as I was talking about a minute ago. So was he infectious when he went to the party? Yes. He was. Now then, we've talked about chickenpox contacts in pregnancy, haven't we? We've talked about parvovirus contacts in pregnancy, erythema infectiosum. What about measles? Now, measles doesn't cross the placenta. So you can't get transplacental infection like you can with parvovirus. You don't have that problem. But it's a nasty infection. So what does the Health Protection Agency say you should, or what do they say you should do? It's D. Yeah. Okay. So MMR should be offered to any exposed healthy individual who is unvaccinated or not completely vaccinated and has not had measles in the past. So you could check the serology. Standard, of course, is 2 doses, isn't it? 2 doses of MMR is the usual. You normally have one at about 13 months and one at just preschool, about 3.5 years. So normally 2 doses. So, and lots of people have not had their MMR for various reasons. Okay, so this is a BLS question. 55-year-old man, collapsed, unresponsive, no respiratory effort, no palpable pulse. What are you going to do? You've done the shake and shout, he's unresponsive. You know, look, feel, listen, nothing. Start chest compressions? That seem reasonable? Yeah. Okay, exanthem again, 2-day history of the rash shown below. 7-year-old. Not a great photo, I'm afraid, but what is it? This is supposed to show that it's vesicular. This little picture here. So in case you can't see it, this is a vesicular rash on a erythematous background. Therefore, it is chickenpox, isn't it? So measles, we've already looked at that a few slides ago. Morbilliform rash, maculopapular. Rubella, what does that look like? Looks a lot like measles, just finer. Yeah, and often it can be really, really indistinct. Sometimes it's a bit more distinct if you're a bit older, but a fine morbilliform rash. Chickenpox, of course, that. What about roseola? Roseola, that's human herpes virus 6, roseola infantum. What does it look like? Okay, just scattered, just a handful of spots. Roseola, all you need to know about roseola is they get a high temperature for several days. Everyone says, what's wrong? And then the temperature suddenly drops and they come out with a few spots. That's roseola, and then they're better. It's not important. And furunculosis, what's that? Infected hair follicles, isn't it? Good, chickenpox. Okay, what about bites? He's been bitten by his partner during a domestic dispute. Wound is not bleeding, but the skin is broken. Okay, so this again is from a guidelines on bites, and the answer is A. So where does that come from? It comes from here. So this November last year, this is just a sort of summary table. So this talks about human bites, cat bites, and dog bites. And it classifies into skin not broken, skin broken but no bleeding, skin broken plus bleeding. Yeah, so it's a 3x3 table. So humans, cats, dogs. Dogs in general are the least serious. So no antibiotics if it's not broken the skin, not surprisingly. And then, you know, this is a tiny bit arbitrary, this separation, whether or not there's been bleeding, but it's supposed to indicate the depth, I guess. Humans, human bite, it depends on where the bite is. So high risk areas. So if you get bitten on your hand, well, it's got the list down there, then those areas are said to be high risk and you should use antibiotics. And then some people are going to be high risk because there's diabetics, etc. Cat bites are also sort of coming along with humans as quite dangerous. Dog bites, not dangerous, generally speaking. And so dog bites, you only really worry about them if they're really quite deep or quite a lot of damage. All right, so that's the table for bites from the NICE guidelines. Okay, so we've already had this subject a little bit. So she's 45, she's not feeling very well, weak, nauseous, and abdominal pain. She's tachycardic and she's hypotensive, and a venous blood gas shows that she's got a metabolic acidosis with the highest lactate, sodium 126, potassium 6.4, glucose 2.6. This is a Addison's. Yeah, everyone happy with that? So before you reach for the treatment, IV hydrocortisone, you must, if it's a new presentation, do what? take blood for cortisol and ACTH. That's right. Yeah, because you'll never have another chance of proving for certain that she's got primary, so Addison's disease rather than syndrome. Okay, 78-year-old man, coffee ground vomiting, and suddenly deteriorates and becomes shocked. He takes dabigatran for stroke prevention. Yes, very expensive, but it is the reversal agent for dabigatran, idarucizumab. Okay, 43. Patient with small cell carcinoma of the bronchus, breathless. You've done an echo in life support, an ultrasound, and got that image.
Cardiac tamponade.
Okay, which view is this? Anyone confident to say?
Parasternal long view.
It's a parasternal long axis, isn't it? So this is right ventricle. This is left ventricle. This is aortic valve. This is mitral valve. This is left atrium. Okay. So this is the free wall of the right ventricle. This is the free wall of the left ventricle. So what is in this view that shouldn't be? Fluid. Fluid behind and fluid anteriorly. Okay. And it's got a small RV, so it's not a pulmonary embolism. It's tamponade. Yeah, that's the concern. Pericardial fluid. Okay, bit of a funny one. She's had a lumbar puncture as part of her neurological workup. And she just has terrible headaches since, can't sit up. She's come back 3 times, sobbing with pain from this headache. And she's got children and stuff, and she can't, you know, it's just impossible to manage this. What's the treatment at this stage? It's what's called a blood patch, isn't it? Take some of her blood and inject, because you're trying to mend a little hole in the dura, aren't you? She's got a hole in her dura when the LP needle went in. This is why we're supposed to use, they're called atraumatics, you know, the LP needles, so they don't make a big, they just make a tiny pop rather than a big cut, so that you don't get this problem. Okay, and final question is an organ donation question. So he's had a head injury and his wife says he's unsurvivable head injury. She says, well, he has said something about organ donation. What are you going to say to his wife? Now, I think this news got swallowed up by COVID, because Wales introduced a presumption of donation about 4 years ago. And UK followed last year.
Yeah.
So there's now a presumption of consent. Yeah, unless there's objections raised. The presumption is to consent. So the answer is E.
So basically, by default.
Right. So so the good question here, even in the case of it would have to go through the coroner. The coroner would have to agree. So if it's in the context of anything that's going to be referred to the coroner should agree. But the coroner will usually agree unless it will interfere in an important way with evidence. Yeah. So, on the assumption that, well, he's got a head injury, this is taking his, organs from here. They will agree. Was that a question at home? Kimani?
I was just wondering, because you said in the question that actually he was assaulted, would that make any difference to it? Because it would then have to be referred to the coroner as an assault. Yes,
we were just discussing that in the room here. Sorry, I may not have been very loud enough. the coroners have guidance on this, and that the coroner would have to agree to the organ donation. So they have a system where somebody would have to phone up. Well, it would be the nurse, the SNOD, the specialist nurse for organ donation would phone the coroner's officers. They'd phone the coroner because they have to consent to it, because the coroner has possession of the body in this case. So they would have to consent to it, but they generally will, unless there's a really good reason not to.
So in this aspect, in England, everyone is by default presumed that they
Yeah.
would donate their organ
Yeah.
unless you opt out.
Yes. So comment in the room here, there is a presumption of consent, and I'm sorry, I haven't got the exact date, but it was, I think, last year. It's very recent. Yeah. Presumption of consent unless you opt out. So you can opt out, anyone can opt out while they're alive. And if the family objects strongly, it probably wouldn't go ahead either. Though strictly speaking, legally, the state could say, sorry, we're having the kidneys, but it won't usually happen if there's strong objections. But the presumption is now in favor of organ donation because we're so far behind, with the demand. Okay. All right, let's have a break now. We're doing quite all right, aren't we? So shall we say, come back at 10 to, do people want to, have people done paper 6? Yeah, people done paper 6? Should we just come back at, well, yes, have a break though. Let's give me a break. Give me a break, mate. Let's come back at 10 to 3 and we'll do paper 6.
10 to 3.
Yeah, 20 minutes. Okay, before we dive in to paper 6, can I just check, can people hear me at home? Can somebody just confirm you can hear me?
Yeah.
Great, thanks.
Yep.
For those of you at home, can I just mention you should, in your email, have got a SurveyMonkey request. That's to give us, that's your evaluation form. And if you could do that, we'd really appreciate it. In fact, it'd be best if you could even just do it sort of right now while I talk, before we do paper 6, because we find that if we leave it till after the course, we don't get many back. And so if you could do it now, we'd really appreciate it, because we really rely on that. We need to know how well this worked out for you. So please, if you could fill in the SurveyMonkey form. It's only a few, how many questions is it, Karen? It's only about 6, isn't it? It's quite fairly straightforward. And send it back, that would be really great. I know somebody's done one already, but if you could look for that, that would be great. For those of you in the room, it's a paper version. So it's in your folder. Karen, is that right? Yeah, so again, if you could fill that in before you go. Now, before we go into paper 6, I just wanted to give a moment to talk about the actual conduct of the exam itself, if anybody wanted to talk about that. So people all familiar with the whole Pearson VUE process, and if you do it at home, what's involved? Yeah, is that all stuff that people know about? You've already made your choice, haven't you? From listening to people, it sounds like Pearson VUE works quite well, apart from maybe disturbance of people coming and going, but it otherwise works quite well. You don't have to worry about your internet. But if you are doing it at home, of course, you will have a proctor. You're all familiar with this term. You get somebody will watch you through your own computer camera, and you will have to log on early. And they will do a sort of security, they may do some sort of security check. You ask you to turn your laptop around and view the whole room, etc. And to make sure, and they may interrupt you if you seem to look under the table, or there's someone else comes in the room, or anything like that. So it's worth having a think through, how am I going to have a really reliable internet connection and really be undisturbed, etc. for the whole exam. And of course, it's 4 hours altogether, 2 2-hour papers. Any, obviously I haven't ever done it. I've only heard about it, but is everyone pretty familiar?
The pass mark is thought to be kind of.
No, so the question in the room here about pass mark, no, we don't yet. We'll only know that. They used to give us all of that after the exams. They'd give us all, the performance, but now they just write a report. And so we haven't had a report since 2019, so we're a bit behind on data about exams. Again, this is a challenge for the college, and they've never done this exam before. They're going to have to, they're going to run it, and then they will do, I would guess, they will do a lot of analysis on it, because really valid exams, a really valid exam is one that tests what it's supposed to test. So they will be looking at how questions compare with each other. When you've got unexpected results on a question, they might take it out, for example. They usually, in the intermediate, used to take out 1, 2, 3 questions every time, because they didn't perform very well. They didn't test the right thing. People misread them or something. So this is all, this is all new stuff for the college. So, I imagine they're going to have to work very hard, because there'll be a lot of people doing it to make sure that it's a really, that they can defend the results, because they'll have to be able to do that. So.
Dr. Ian, my question was that the total paper is 2 hours, and the total number of questions we have to answer in 2 hours is 90.
Mm-hmm.
So
then repeat.
It's 45 questions for 1 hour.
Yes.
So I was thinking that according to it will be a time crunch, because 30 minutes and 45 questions. So how the time distribution should be thought, that was something which I wanted to.
Okay, yep, thank you. And I'll come back to the online question in a second. So you've all done so many exams by now that you have a system, but what we do say to you is make sure that you use a time target. So for your 2 hours, make sure you've got yourself at least a 1 hour target. By 1 hour, I will have done 45 or even 47, so that you leave yourself time at the end. We know that you get more success from finishing all the questions than you do from sweating over the hard ones. Yeah, the yield per minute of work is greater. So make sure you finish the paper. You've got to finish the paper. Don't get behind. Get a system so you don't get behind. And try to have a system that gives you a few minutes at the end to go back. Because I think normally you can flag questions. So there'll be a system online so you can flag them and come back to them easily. Is that helpful? I don't know, but just have a time system, because I think this will be easier than the intermediate. Intermediate was terribly time pressured because of the need to write. Everybody works to the wire in the intermediate, the old intermediate. This might be easier because it's a choice option, a choice of options. You don't have to write stuff.
Will there be any kind of calculation?
So question here in the room about what about calculations? They might ask you to choose, which of these is the, for example, how do you calculate deficit? Which of these three is it? But they won't get you to do maths, mathematics.
But in case if they're asking to choose the value, that means that still we have to calculate that.
No, not to choose the value. They might say, is it weight versus, percent deficit times 10, or weight versus deficit times 20? Do you know what I mean? They might give you a formula. But they know, just talking about validity, that getting people to do mathematics often leads to errors and is not a good test of your ability to be an effective emergency medicine doctor, which is what the exam is designed to do. The exam is designed to, the underlying purpose is, are you ready to be a sort of on your own shift leader in emergency medicine? Able to deal with the everyday emergency medicine stuff. That's what this is, the exam's designed to do. Yeah. Final is about, a bad day. This is supposed to be about a normal day of work, normal stuff. So the exam has got to test that. It's no good if it's testing something else, like ability to do mental arithmetic. Sorry, there was somebody online. I wanted to come back to you online.
I know you said you couldn't say what kind of percentage was the pass mark, but could you suggest, for those of us who are using question banks as well, whereabouts in the pack we need to be falling? Is it usual that only 50% of the people taking an exam pass, or 40%?
Yeah, that would be historically, and of course it depends also on whether you're in UK trainees tend to get around the 70-odd% pass rate has been typical. Yeah, people in UK training, but overall pass rates usually been around 50 for the intermediate. It's all on on the college.
When you say pass rate, you mean the amount of people passing
Passing the exam.
The actual...
I could show you the reports for the intermediate. I'm not sure if that'll be useful.
There's only 27% of participants passed the exam on the last sitting.
Yeah, we've got all that data. I don't think that's true. Do you mean for the intermediate SAQ?
Yeah, only 27%.
Okay, actually, they haven't released that data yet publicly.
No,
They send it to you.
Yeah.
That's horrible. That's awful.
27%.
Okay. All right. That isn't publicly available because they haven't reported 2020's exams publicly yet.
Yeah, the examiners report now. They sent us an email to let us know.
Okay. Well, that's awful. That's not normal. That's not normal. Normally, it's about around half. But we've got the data for years. We can show it to you. Yeah. Well, but then you think, well, maybe it's an atypical. Do you know what I mean? Maybe it was. Sorry, there are a couple of other hands. Did I answer your question online? Sorry, I've lost track now. Kimani.
Yes, thank you.
Yeah. So there was a couple of other hands. Did you hand up? No.
I'm trying to remember for the last sentence, did they give us the normal values and emphasize, you know, that they give MCQs? Can you remember them? Yeah, they did.
Usually there will be a document that has the acceptable abbreviations. Yeah, so there, for example, BP is okay, ECG is okay, but you know, you can't be very careful. You can't usually abbreviate conditions. You might be allowed COPD possibly, but you know, don't be careful about abbreviating conditions because there will. You've got to be. You can only. Mind you, don't need to, do you? Yeah, you're not writing. Yeah. And normal values will be there. Yeah, they won't give you a blood test result without a normal range.
I was going to ask, I don't suppose whether you know this, the last exam, and I know it was a different exam, because it was in the Pearson view and it was on like a bank, all of the questions were generated in a random order. So like my order is different to his order to different to their order.
All right, I didn't know that.
Yeah, no, neither did I. Going into, do you know if that's still the case? You don't know.
I don't know. I don't know. Don't even know why they would do that, but
yeah.
But it's because, of course, we've written one. It was never like that. Why would they do that now? I don't know. But I know you had your hand up at the back there. So.
A quick question. So altogether, we've got 180 questions.
180 questions altogether.
80 questions.
Yes.
2 hours.
So 90 break 90. Yeah. I don't know how long the break is in between. But
And the total time will be
1 hour. It's a 1 hour break between. So it's a 5 hour activity.
so 2 hours exam, 1 hour break, and then 2 hours exam.
Yes.
It's like an MRCP or MCQs.
Yeah. Yes, that's what I understand.
Why divided into two? And why it's not like you?
Why? Because it's just too. It's just humanity. It's just about being, you know, giving you a biological break. You know, go to the loo and stuff. Drink some water. Have a coffee. That's all. Because you can, if it's Pearson view, you can't even take water into your room. I don't think. You can't take. Yeah, right.
In the Pearson View Center, it's different from center to center because in some centers they're giving plastic placards, so they can do the. If you have to calculate serum osmolality, they're giving a pen and the plastic paper to do the calculations on there.
Right.
But in some centers they are not giving that to do anything, so you have to do a mental math in the brain.
I believe that there's an online thing on the screen. There's something there you can. Scratch pad. Yeah. Okay, but I don't honestly think. I don't think they're going to get you to add up, you know, replacement and maintenance fluids and stuff. There's a discussion here in the room about where can you take notes, but we think it's possible, but it's not that easy. I think is the short answer, isn't it? It's possible, but it's not an easy thing to do. But mostly, you shouldn't need it. I think.
You get a certificate for
The CPD certificate from today, yeah, for this course, yes. You get it comes out by email. Everyone gets you'll all get a CPD certificate. Okay, so I hope those of you at home have taken this opportunity to do the Survey Monkey for us. I hope you have, because it would be really great if you could send those in. Let's go on to paper 6. Okay, so. Okay, a subject we've looked at quite a bit, bleeding and warfarin. She's got an INR 5.4. She's still bleeding where she had a tooth taken out. So it's you have to remember that 3x3 grid. Which one is this? This is minor bleeding. If it's a tooth socket, it's not major bleeding like a stroke. It's minor bleeding, and her INR is in the middle category, 5 to 8. So in the middle category, it's stop the warfarin and give IV vitamin K. Yeah, so it's this box here. Everyone okay about that? Yeah. Good. Question 2. So an old lady's come in with multiple bruises. And so the question is, when do you break confidentiality? It's exactly the same as we discussed yesterday. It's no different. So if guns or knives were used, you'd report it. If you, of course, not relevant here, but if you were worried about a child, you could break confidentiality. Or if the person lacks capacity. Yeah. So if she's got Alzheimer's. But if she has capacity and she doesn't want the police involved, you know, this is a difficult one. This is the domestic abuse situation, isn't it? The woman who comes in bruised and it becomes clear it's domestic abuse. You cannot report that without her consent. Yeah, you can't report domestic abuse without consent. You can try and persuade, but you can't break confidentiality. Okay, is that all right? Everyone okay with that one? And this is a bit of GMC stuff about it. And this is the summary at the bottom here. Okay. Dig toxicity is this question. Here's an ECG. So ECG, sorry, did you get the answer?
Oh, yeah.
ECG, what's true about that ECG, but also a feature of dig toxicity? Yeah, E is the right answer by Gemini. If I go back to it, this pairing of complexes is one feature of digoxin toxicity. The commonest feature of digoxin toxicity is STT changes, yeah, classically the reverse tick. You see this? This is the reverse tick. So it's like a sort of a tick backwards. But you can also get atrial extrasystoles by Gemini, and lots of other things as well can happen. Of course, aggravated by which biochemical abnormality? Hypokalemia. Good. And if you discover she's seriously digitoxic, what would you do? Apart from correcting her potassium, give Digibind, yeah, which is a monoclonal antibody, isn't it? It's an antibody against, so it's a Fab fragments against digoxin. Okay, right. 14-year-old boy, bicycle accident, femur fracture, cannulated coagulation profile, and his APTT shows this, ratio 1.9, seconds 49. Now, I haven't given you the normal range, but the ratio tells you that he's nearly twice the normal range. So what does that, what does that make you think of? Extended APTT in a 14-year-old boy. Hemophilia, isn't it? Yeah. Hemophilia A is the most likely cause. And then what are you going to do about that? He's got a broken femur, so he is at significant risk of bleeding, isn't he, if he's got hemophilia. Hemophilia varies. Yeah, you can get people who have much more trouble than others because the amount of factor VIII varies a bit. And he needs factor VIII, doesn't he? That's what he needs. Just a few things from the clotting cascade. I'm sure you're all have been looking at this for many years back to medical school, but let me just say a few things about the clotting cascade. So the APTT measures this pathway here, the one that runs from factor 12 to factor 10. Yeah, that's what APTT measures, whereas the INR measures this side, yeah, the extrinsic pathway that starts with factor 7 here. The clotting pathway all hangs on factor 10. That's the one that sits in the middle, yeah. And so this is where you go from factor 10 to factor 10A. That activation then causes a massive explosion here, and you get 1,000 prothrombin to thrombins for every one factor 10A, yeah. So you get a lot of acceleration at this point. So it's all about 10 to 10A. Dabigatran blocks this conversion, prothrombin to thrombin, whereas rivaroxaban, apixaban, etc., block the activation of factor 10. This is also where all your antithrombins work. They act by binding to antithrombin 3 and again preventing this activation. So a lot of stuff happens here. Warfarin. Warfarin inhibits what? All the vitamin K dependent factors, which are 2, which is this one, 7, which is this one here, and 9 and 10, 9's there, 10's here. So you could say, well, if you haven't got 2, 7, 9, and 10, well, why don't you use the APTT? That would also be affected because it goes through 9 and 10. But we do this one that starts with the 7 from 2, 7, 9, and 10. That's the one we use to measure warfarin effect. Okay, I think that's probably enough on that. Good, okay, let's move on from there. Erythema, erythroderma, actually. What's the definition of erythroderma? What is erythroderma? Generalized erythema, isn't it? And there are a number of causes and many idiopathic causes. And by definition, you need to have, how red do you have to be? Bright red. 90%. 90% all over, yeah. To get, and then what are the causes? So drugs, various drugs can cause it. It can be a feature of psoriasis, yeah. And then it can also be idiopathic. So drugs are likely to be the cause here. Just a little bit on erythroderma. It's one of the few dermatological emergencies that comes to us. So here's the definition, 90%. Causes, here's a list of causes. So psoriasis, maybe eczema, lymphoma, and lots of different drugs. And idiopathic. Okay. Question 6. In a teaching session about alcohol, there's a discussion about the number of units in different common drinks. Which of the following has the highest number of units? Okay, so how many, what is a unit? What's a unit? Why do we talk about units? What is a unit? Yeah, it's 10 mils of alcohol. Yeah, 10 mils of ethanol. So when you go to the bar and you ask for a single vodka, how much volume of vodka is that? It's 25. So of that, 10 is alcohol. Yeah, and 15 is other stuff. Okay, so 10 mils of absolute alcohol in your vodka. So how much absolute alcohol in a bottle of wine? How many units? So out of 750 mils, or 700 mils, yeah, 9 is the, of standard wine. So 90 mils of alcohol in the 700 or what. Okay, what about in a pint of beer? Ordinary beer. 2 units. What about strong lager? 3, maybe 4. A glass of wine, average glass of wine, not a big glass. 2, big glass, 3. Okay. So 4 pints of strong lager, that's going to be 12 plus, isn't it? 3 glasses of champagne, 6. Bottle of wine, 9. 2 double shots, 4. 4. 3 1-pint cans normal beer. So 1-pint can is 2 units. So that's 6. Okay, so which is it? A is the right answer. Yeah. Oh, by the way, talking about alcohol and DVLA, I'm looking at you because for no other, so we had a discussion in the room earlier about the DVLA guidance and how is it, what the guidelines say. I looked it up in the break and it said that after medical inquiry. So I don't quite know what that is, but basically the onus is on doctors to say if you're drinking or not. The point is, you know, you're supposed to be 1 year free of alcohol to start driving again. And it's, you'd have to convince your doctors you're not drinking and also have normal chemistry, etc. No normal LFTs and stuff like that. So and they've had no alcohol related problems. So the onus falls on doctors to say. 7. Okay. So let's just touch on the whole issue of alcohol, harmful drinking. So we see lots of people with alcohol-related problems, don't we? In loads and loads of people, and some of them are alcoholics. There's said to be 1.5 million alcoholics in the UK, not all of whom are identified. But there are more than that who have what's known as harmful drinking. So people who are not yet dependent, physically dependent, but they're drinking too much. They're going out every night. They're having 3 pints. They're having having domestic problems. They're having work problems. They're having road accidents. They're falling over, breaking their ankles, that sort of thing. That's what's called harmful drinking. There is a pressure on us, because we in emergency medicine see these people because of the accidents, to try to intervene, because it's much easier to help this group, the harmful drinkers, than it is to help alcoholics. People who are physically dependent, really hard to change, isn't it? Really hard to change that. But harmful drinking is much easier to, even a single brief intervention, as it's called, just talking about it, will work on some people. You know, look what's happening to you. Yeah, is this who you want to be? That sort of thing. What's happened to you? You crashed your car or whatever it is. So that's what's called a brief intervention. And so we're supposed to detect harmful drinking using questionnaires, such as the Audit C. People have met the Audit C tool. So it stands for Alcohol Use Disorders Identification Test, Audit C. It's just a short 3-question screening tool for picking up harmful drinkers. And so we are expected to look for drinkers and try at least to do a brief intervention. But if we find case questionnaire is an alternative, yeah, it's an alternative one which has been around for a few years. This is a particular one pushed by NICE, Audit C. There is a longer thing called Audit C as a subgroup. But what if you find it? What if you find he's got harmful drinking from your audit survey? What are you going to do? Yeah, E. That's all. That's really all it's getting at. This is not about. This is not about alcoholism and dealing with alcoholism. That's another discussion. This is about picking up harmful drinkers. So it's where alcohol is or is likely to cause you harm. Okay, so that's just a quote from NICE about this. This is just a little bit of guidance on alcohol content. So here's a bottle of wine, 9 units, etc. Strong lager, 3 units per pint. Okay.
Being what, like percentage-wise, 5%, something like that.
Premium, which is that one?
So kind of strong or premium beer, or lager. Is that like saying percentage?
Yeah, the higher strength stuff. 5%, is it?
Yeah,
4.5%, 5%, that sort of stuff. Yeah. What does it's written there? But what's the guidelines? Chief Medical Officer's guideline for safe drinking? You should drink no more than 14 units a week, and it's the same for men and for women. Used to be different, but it's now the same. Question 8. 21-year-old presented in the early hours of a Sunday morning, says she's raped a few hours earlier at a party. Arrangements have been made for her to be transferred for forensic assessment. Which is the highest priority in the ED before transfer? Yeah, it's D. Yeah, prophylaxis for sexually transmitted diseases should be discussed and provided. There's also, sorry, what's the word for it? Oral contraceptive, you know, so post-exposure contraception. Yeah.
Who's supposed to take the vaginal swab?
So just a few, I think we'll come back to, I think we'll probably do a bit more on this whole subject, but the whole issue of forensics, anything that's forensically important, there's a whole, brings in the issue of chain of evidence. So for anything to be admissible in a court, there's got to be a clear and safe line of, well, how do we know that that swab is from that person? Do you see what I mean? And there has to be, and that's why it's best done by a forensic medical examiner. So they will do it all in a way that will stand up in court. It's not going to be challenged. So we should avoid getting involved in forensic stuff. But if we have to, for example, we have to remove something, there's one thing is it shouldn't go in a plastic bag. Do you know about it? It should go in a paper bag. Plastic bags, particularly at room temperature, denature DNA. And if DNA turns out to be important, you're supposed to put things in a paper bag. But we should generally get the FMEs to do all of the stuff. Well, I'm sure we'll come to that. We might be coming to it quite soon. 21-year-old female, early hours of Sunday morning. She knows who is responsible and wants the police involved. Oh, here we go. Which of the following are most important in preserving evidence? Well, it's the same thing. C, refer to the SARC. So all of this comes from this guideline, which is the management of patients with sexual assault and or rape. And if I just go through a few things here. So where possible, they should go to a SARC. Now, I only know from South London, but there's one called the Haven at King's, which is the one that's sort of quite well known in these parts. But I imagine there's similar things around the country, which is where you send the patient to. Forensic examination only performed by clinician with suitable specialist training. Emergency contraception, it should be provided from ED, as should post-exposure prophylaxis for STIs. Okay, yeah, that's all I've got on that one. Okay. Question 10. 21-year-old man is presented with a very painful throat. He asks if you'll prescribe antibiotics, and he's got a pretty horrible looking throat. Which of the following would make you more likely to recommend antibiotics? So can you tell, well, it's the same thing, isn't it? It's all about limiting access to antibiotics, isn't it? You can't tell by looking at it. He hasn't got a quinsy. So what will help you? Well, rapid onset may well mean bacterial. So let's have a quick look at the two scoring systems. So these are the two scoring systems. You just ignore these numbers. I think these are the numbers for perhaps for that patient, but fever, purulence, rapid attendance, severe inflammation, absence of cough are the 5 components to fever pain, and Centaur's got 4.
So do you just pick one of them?
One of these, yeah, they're both the nice lists them both. This is the nice guidelines. It's got both of them. And neither of them are perfect, because even if you score 4, if you score full marks, it's only about 50% predictive of bacterial. So they're not that great, but it's just a way of increasing your sensitivity or specificity, I suppose. Ruling out, yeah. Okay. Question 11. A 37-year-old woman who normally lives in the UK has returned from visiting family in Nigeria. She's been unwell for 2 days with fever, headache, and diarrhea. How would you quickly establish if she has falciparum malaria? Yeah, exactly. Heme sustained thick and thin films. The thick film is the higher sensitivity. The thin film gives you the species. But a full blood count doesn't confirm malaria, does it? You know, she might have a low platelet count. She might not. It doesn't tell you, particularly if she's got a low parasite count.
What about C?
So ELISA, well, usually the ELISA isn't available. Well, it won't be that quick, generally speaking, as malarial thick and thin films. Okay. And anyway, I think that ELISA-based looks at her IgG, doesn't it? Whereas the rapid test is antigen-based. There's rapid antigen testing. You can, do a rapid antigen test. Works quite well for falciparum, not so much for the other 3 species. You can detect antigen. That's the alternative to heme sustaining. But still, heme sustaining is still the mainstay of diagnostics, isn't it? Because it also gets mixed infections, etc. Okay, while on the subject of malaria, she's got a low count of falciparum. Which is the most appropriate? Yeah, it's D, isn't it? Yeah, D is malarone, atovaquone with proguanil. So anyone know when you'd use primaquine? Vivax Novali to treat the liver stage, to stop it coming back again, because they have this dormant liver stage, don't they? They can get another attack next year or 2 years' time, up to 5 years. Chloroquine, again, Vivax, Ovali, malariae, all treated with chloroquine. There is some chloroquine, a little bit of resistance in Vivax, isn't there, with chloroquine, a little bit, but it's mostly sensitive. Proguanil, well, it's part of malarone and it's also used as a prophylactic. Yeah. Doxycycline, does doxycycline work for malaria? Yeah, it is, isn't it? It's quite effective, actually. It's not quick, doesn't kill it quickly, but it's often used as the second drug. So you treat the falciparum. We know that if you just treat this falciparum with quinine, for example, which we do a lot in the UK, you still may have it come back again. So you have to give a second drug. And doxycycline is a good choice, second drug. So here are some malaria guidelines. That's the malarone here, quinine. Okay. '13, so a headache question. 64-year-old man, severe headaches. Which of the following features would make trigeminal neuralgia more likely? Just tell me what are some features of, I'm just checking if that clock's right. This is it. Features of trigeminal neuralgia. Yeah, lanculating, as it's often called, like shock-like pains. Very short, aren't they? Where? Trigeminal distribution, often on the side of the face, aren't they? Yeah. Trigger points or triggers. So a draft or cleaning the teeth or touching the face can set the pain off, can't it? And they get these triggers which give them attacks of pain. And they get multiple attacks of pain in a day, can't they? Trigeminal neuralgia. And again, very severe pain. Treatment, first line is carbamazepine, yeah. So that's the answer I was looking for. Okay, and that just tells you that carbamazepine is the mainstay of treatment. So just wondering if there's anything else to say about headaches. I'll come back to headaches. I've got another headache question, I think, coming up. Oh. 3-day-old boy brought to the ED. The baby was well, but for the last 12 hours, he's feeding less and having episodes of turning blue. On arrival, the baby is alert but in respiratory distress with marked costal recession, heart rate 200, saturation is 88%, capillary refill 4 seconds. What would be the most useful sign to look for on examination? So what's this getting at? What's this question getting at? Yeah, a lot of people saying about cardiac, but a very particular type of cardiac problem. I'm listening out for the word duct. Did anyone say duct? Duct-dependent congenital heart disease. Yes. What's the story there? Okay, let's just quickly go over this. So you're in utero, you don't send much blood through your lungs, do you? No point. So to get your blood from your right to your left, you send it through your foramen ovale or through your ductus arteriosus, yeah? Because there's no point sending it through the lungs. You have a shortcut. And then when you're born, you get these pressure changes and that shuts the foramen ovale. Once your lungs open up, there's low resistance then through the lungs. And so that has an effect on the atria and your foramen ovale starts to shut. And your ductus arteriosus, yeah, the ductus arteriosus starts to shut then and shuts over about 3 days, doesn't it, usually? And it closes up. You can keep it open with prostaglandins and you accelerate its closure with antiprostaglandins or non-steroidals. Okay, so that's usually great. You don't want it anymore. You don't need it. Now you're extra utero. But in some congenital abnormalities, you may need it. For example, if you've got transposition, yeah, your aorta and your pulmonary artery are switched round, you've got no connection between your right and your left except arterial side, but except the ductus. There's no other way of blood getting from the right to the left because your right side is going through the pulmonary, is going up and around, and you get this transmission, and there's no way of it getting around the whole body. So some people are duct dependent, and so once it starts to shut, they get into trouble. So on the day of delivery, they were fine, and many babies go home early these days, don't they? On the day of delivery or the next day, and so they're fine. And then a day later or so, and that's why we see them in ED, because their duct closes and they get into trouble. And so how are we going to tell in this collapse, how do we distinguish it from sepsis, etc.? And so we look for cardiac features. And what are they in neonates? The features of heart failure, if I put it like that, or congenital heart disease. They get a big liver, which may be pulsatile. Yeah, but that would be lots of things. They may be cyanosed, which doesn't go away with oxygen. Cyanosis is not relieved by oxygen. Yeah, murmurs and absent femoral pulses. Okay, those are the sort of key findings. Okay. So it's one of the things that we need to know about because it comes to us. These are some of the duct-dependent diseases. Okay. Carbon monoxide poisoning. and you need to transfer the patient, and you want to keep the patient on high flow oxygen all the way. And so what device? It's a sort of easy one really, isn't it? I just want to make sure everyone's sort of knows we have 3 different types of masks, don't we? Why? Why do we have all these different masks? What's the point? It's all to do with peak inspiratory flow rate and wall oxygen, because the wall oxygen comes out at the maximum is 15. But when you breathe in, how fast do you breathe in at the peak? Maybe 60. So you breathe in faster than the stuff comes out the wall. So there's a problem, isn't there? If you just took the tubing, put it by your mouth and breathed it, you would pull in room air, wouldn't you, as well as the oxygen. So if you use a very simple mask, it'll help a bit because the mask fills with oxygen, but you'll still pull in room air. And do you know what I mean by a Hudson mask? An ordinary simple mask without a bag, you will pull in room air. And the faster you breathe in, the more you will bring in room air. So we get round that by adding a reservoir, because then when you're breathing out, the oxygen tubing is filling the bag, so that when you breathe in, you suck in oxygen from the bag as well as from the supply. Yeah, that's why we have neural rebreathing masks. Venturi devices, they work in a different way, don't they? They work through something called the Venturi. They work through the idea that if you have a jet of gas, it has a low sideways pressure, sucks in air, and you get a fixed concentration mixture. It's called the Bernoulli effect. Take a while to explain it, but they create a much higher flow into the mask than the setting. So even though you might put the gas on 2 liters on the wall, the actual flow into the mask is much higher than that, but it's a fixed mix. And that's how they work, Venturi masks for COPD. Okay, so what's the right answer here? Non-rebreathing mask. Okay, linked to this is what about how much oxygen you're going to send with him? So there's just a couple of tanks just to be aware of. There are really 3 types of tanks that you see. You know the long one, the one that you've got on the bottom of the trolley, that's called an F. If it's from British Oxygen, BOC, it's called an F. How much does that contain? Anyone know?
360?
Yeah, it's just under 1,500. It's 1,360, I think, when full. And so if you've got somebody on 15 litres a minute, 15 litres a minute, they will need, what's that, in an hour, they'll need 900 litres in an hour, okay? When you send somebody in an ambulance, what's the calculation you're expected to do to work out your requirement? Journey time times 2 times flow rate, yeah? That's what your calculation is, isn't it? So even though you've got an hour and a half in a tank, if your journey's an hour and a half, you take 2, yeah, for an F. This is called a CD size. How much does that contain? Yeah, it's about 460, isn't it? The good thing about CDs is you can put the oxygen tubing straight onto them, whereas with an F, you've got to have one of those, reducing valves with a little bobble in it. Okay. The other one is a C. There's a smaller one called a C, which you sometimes see on the side of a trolley. Little one about that long, with a which it looks like, which doesn't have this here. You have to have a reducing valve on it as well. That's about 300 litres. Yeah, you sometimes see it on the side of it, but those are the main ones. There are other sizes, but those are the main ones. Oh, here we go. Sorry, it's not a C, it's a D. This one, 340. Okay, moving on to testicular pain, scrotal pain. 10-year-old, acutely painful left testicle. I mean, it's pretty obvious, isn't it? What diagnostic tests can you use for torsion? So ultrasound. What can you get? What can you get from ultrasound on a testicle that's useful? Blood flow. Yeah. The problem with that is if you don't keep the probe very still and you move the probe, it also looks a bit like blood flow. So yeah, you get false positives. But blood flow, but also the twist. It's even more reliable if you see the twisted cord like a rope. That's the more reliable option. Okay. So torsion, bell clapper deformity, what does that mean? You're familiar with this? So the idea is the tunica vaginalis shouldn't go right the way around your testicle. So at the back, it's supposed to be adherent to your scrotal skin. But if it goes all the way around, then it's dangling and can twist. That's the problem. Epididymoarchitis, if you get a question about this, bear in mind that young men, it's usually in sexually transmitted diseases, chlamydia, gonorrhea. Old men, it's usually because of prostatism, E. coli, stuff like that. Okay, I'm going to skip that and go on to this torsion of the hydatid of Morgagni. Very occasionally you get somebody with just a localized area of pain in the scrotum, and you get these little appendages called the appendix of the testis, and they twist. It's trivial, it doesn't matter in any important way, but they get a pain and they get a little dark dot through the skin. Question 18. So this man's fallen through the loft and he's broken his femur. Skin traction, isn't it? So the benefits of traction include analgesia, reduced blood loss, reduced soft tissue complications, nerve damage, etc. So a lot to be said for skin traction or for traction of any sort.
Sorry, can I just ask a question about that? So the wording in mine on my paper here says what would provide the best analgesia, whereas that says the best early analgesia.
Okay. Well, I think we've tried to nudge it to make sure, yeah.
Because early analgesia would obviously be traction, but the best analgesia would be a block, because then it would feel it.
Yeah. I think that's why we've changed it.
Right, okay, so.
Yeah, that's why I changed it. So apologies for that. Just trying to. Okay, a mental state examination question. You're worried about whether this guy's got a psychosis. Which parts of the mental state examination may have symptoms that confirm that he has? So you remember your mental state examination? I don't think you're going to get very direct questions about it. It's more of an OSCE thing. Yeah, but insight and thought are the sort of main ones that you're going to get. And sometimes people separate off perceptions, auditory hallucinations. So insight. So psychosis, you lack insight, don't you? Okay, headache question. 54-year-old has a headache. She's had a long history of headaches. This began 10 days ago. Felt at the front and sides of the head. Stopped her doing normal things. Normally takes ibuprofen and paracetamol every day, but they're not helping her anymore. Yeah. It can be simply medication overuse headache in people who are chronic analgesic users. This is where it comes from in the fairly recently updated headache guidelines. So it says if you've been having analgesics for 3 months or more, then think about medication overuse headaches. "21. 37-year-old had a motorcycle accident on a slippery road. Pain in his right shoulder, dislocation is suspected, which would suggest a posterior dislocation. Okay, so any dislocation, you wouldn't be able to abduct it. Yeah. Squared off, that's the classic anterior dislocation, isn't it? Previous shoulder dislocations usually means it's anterior, don't they? Because they get a baggy capsule and it pops out more easily. Held in adduction, yes, that's a classic feature of posterior dislocations. They come in like this, the arms adducted across the chest. Sensory loss, that's axillary nerve, that's a classic anterior dislocation feature, isn't it? I think we might have done this one before. 84-year-old man, coffee ground vomit, placed a large bore cannula, bit hypotensive. Well, no, we haven't done this one actually. We've done several around this subject, but not this one. Sorry, go back to the story. He's an old man, nothing about alcohol there. You've put in a large bore cannula. And he's hypotensive. D, yeah. He's a high risk, isn't he? An old man with significant upper GI bleed because he's hypotensive. He's quite high risk, isn't he? Again, we've done this a bit, but 56-year-old drinking an industrial chemical possibly containing methanol. Yeah. So the answer is, so I'll just quickly go over the alcohol dehydrogenase story. So methanol is not in itself harmful. Yeah. Doesn't do you any harm on its own. Ethylene glycol doesn't do you any harm on its own. Neither of them are harmful. They're only harmful after they've been converted by both of them by the same enzyme, alcohol dehydrogenase. What does methanol become? Formic acid. Pretty nasty stuff, gives you metabolic acidosis, and in particular does what? Affects your optic nerve, doesn't it? It's toxic to the optic nerve and it's permanent. Gives you blindness. And so that's the big issue with it. It might kill you from metabolic acidosis or it might make you blind. How long does that take? I think it's sort of like hours, 8, 12, something like that. I don't know exactly. I don't want to, but that's sort of, it's not minutes. So you've got time. Ethylene glycol. So ethylene glycol, you only need a mouthful. It's quite small volume and it's converted again by alcohol dehydrogenase to what? Anyone know? It's converted to 2 different metabolites which are toxic. Oxalic acid and glycolic acid. And those cause the oxalic acid precipitates calcium as crystals in your kidneys. Gives you renal impairment as well as metabolic acidosis. Again, that can kill you, but if you survive, it recovers completely. Yeah, so it's not permanent, unlike the methanol one. So how do we treat it? How can we treat those 2 overdoses? And how does it, this is leading to how do the treatments work? You've got 2 choices. You can block alcohol dehydrogenase with fomepizole, which is a competitive antagonist, or you can keep the alcohol dehydrogenase so busy It can't work on the methanol and ethylene glycol, and they just get passed out in the urine. So how do you keep it busy? With you give them loads of alcohol, usually in a drip. Get a pharmacy to put some alcohol together for you in a drip, or you give, if all else fails, they just drink vodka constantly.
Does the pharmacy stock any alcohol?
I don't know. I would imagine so. So that's the story, and both of these have, you know, you could get one of these as an increased osmolar gap question, yeah, which we've already looked at. Okay, fall on the outstretched hand, and he's got tenderness in the right anatomical snuff box. How else? Clinical signs for scaphoid fracture. D, it's sometimes called telescoping of the thumb. Yeah, you push the thumb back and forward. What about this? I was playing tennis and I went for a big smash and I got sudden pain in my back. And since then, my arm's not right. It feels weak. What's this? Winging the scapula caused by long thoracic, and that's the nerve to serratus anterior. Good. It sounds like everyone knows this. And it's usually caused either by this method or by a blow to the side of the chest. And medically, of course, by chest drain, surgical chest drain, if we go behind the mid-axillary line, isn't it? Because the nerve runs just down behind the mid-axillary line. Okay, so it's long thoracic nerve injury. 26, we discussed this yesterday. Struck in the left eye by a squash ball. Here's his x-ray. What do you think about his x-ray? Yeah, he's got a blowout fracture. So the squash balls hit his globe, caused a wave of pressure, and that's burst the bottom of his orbit. And so his inferior rectus and some other stuff has come down into his maxillary sinus. And he will get what? Diplopia on upward gaze. Yeah.
Is there not any other fracture on the other side as well?
So you could look at a maxillary complex, shouldn't you? Look at his, you know, I'm looking at his zygomatic arch here, and it's, but I wouldn't rely on that. You'd have to correlate that clinically, wouldn't you? And then, so this is where his zygomaticofrontal suture line is. There's the floor of the orbit. There's the lateral wall of the sinus. So 1, 2, 3, 4 are where you would look for maxillary complex injuries. And it's usual to take 2 views, isn't it? Yeah, OM10 and OM30. So you can take 2 views, and then sometimes that gets round, and you know where it's equivocal on 1 view. Okay. What about this one? 14-year-old boy. He was sprinting, and he suddenly got terrible pain in his left hip. And he can't, there's 2 injuries, quite similar injuries that they could just show you. Again, they're spot diagnoses, really. Of what? Anterior superior iliac spine. And that what would have pulled that off? Anyone know? Sartorius. The other one that's quite similar story, often, you know, a youngster perhaps kicking, really going for a, you know, penalty, something, really kicking a ball hard, is the vastus rectus, yeah, the quadriceps. So that vastus rectus inserts about there, just above the glenoid, and you can pull off a bit of the pelvis there as well. So those are 2. Can you see it, that there or that there? So they're both spot diagnoses, really. Story will be slightly different. Yeah, so it's that one. 28. 2-year-old says the child's not eating. Child looks quite neglected. Which of the following features would you be most concerned about on examination? Why do you say C? So the question here is, there's neglect and there's non-accidental injury, isn't there? And so they're different, and NAI would be even more worrisome. And so which of those is? So it's the torn frenulum, isn't it? Because that suggests a smack to the torn frenulum usually comes from smacking the face, doesn't it? And the movement of the soft tissues. So quite a strong smack. Whereas the others there may be all just due to neglect, lack of cleanliness, stuff like that. Bruises, of course, are normal in a in a mobile 2-year-old. If they're so, how do we tell whether bruises are NAI or not? If you have a child with bruises, location, isn't it? Yeah. So you're allowed to have bruises on your shins, knees, elbows, over bony prominences, even on the forehead. But you shouldn't have them, obviously, perineum, buttocks, back. So location, also patterning. So fingertip bruises, yeah, or the shape from a stick or a belt, something like that. So what about, yeah, maybe we'll, you can also, obviously, the whole issue of fractures. When is a fracture suspicious? So which sort of fractures? Obviously, skull fractures, any fractures in a pre-mobile child are worrisome, fractures of different ages, but certain fractures like femur in very young children are unusual. Humerus fractures are also unusual. Rib fractures are unusual in young children. They can still occur, but unusual by accident. Okay, an old man with a fall in the street, and he's come in and he's got this X-ray. Okay, so there are 3 types of slings, aren't there? 3 types of slings we give people. Mostly we use broad arm slings. Sometimes we use high arm slings, sometimes collar and cuff. Why do we choose which one? So if you just want to rest the arm, yeah, like you've got a forearm fracture in a cast and you just want to support it, you give them a broad arm sling. You use a high arm sling, yeah, with the fingers here, when you want to elevate, yeah, like an infection in the in a finger, something like that. You use a high arm sling. Collar and cuff, use a collar and cuff when you want to hang the arm. Yeah, you want the weight to pull something straight, such as surgical neck of the humerus or mid-shaft humerus fracture, where you need the weight to pull it out. Yeah, so you want the person sitting with the arm hanging. So that's the, yeah. Is that all right?
They also use a slab for...
Yeah, for a mid-shaft humeral fracture. Yeah, to add weight, basically, just to put more weight on it and make it pull out even more.
In this one, it's completely off-ended. If it distracted, would it not completely fall apart? So there should be some...
Does this fracture, is it risk of non-union or malunion? Yeah. It's not really, is it? Non-union and malunion usually occur in cortical fractures, yeah, where you've got thick cortex. Yeah, like you occasionally get it mid-humerus or ulnar or tibia. Not cancellous bone like that. When you get spongy bone like that, they usually heal very well. Yeah, it's much easier for it to form, go through the callus process. Okay, question 30. Tonic-clonic seizure at home. She's never had it before. She's elderly. CT's okay, but you get her chemistry back and she's got a sodium of 107. So what's probably wrong with her? She's got hyponatremia. Why might she have hyponatremia? Yeah, but how does that, so the response in the room here is malignancy, but how will that give you a low sodium? Yeah, we're looking for SIADH. Yeah, obviously there are a number of spurious reasons of getting a low sodium. You can, if it's a drip arm, if you've got very high lipids, you can get a spuriously low sodium. But usually, Addison's is another cause, but rarely as low as this. Usually it's inappropriate ADH, isn't it? So ADH, you should only produce ADH when you're dry, yeah, when you've not got water. It's when we get thirsty, our hypothalamus tells our posterior pituitary release ADH, and that will act on the collecting duct to open the little doors, the aquaporins, to suck out the water from the collecting ducts so we don't lose it. Yeah, that's what it does, ADH, antidiuretic hormone. It's supposed to conserve water when we're in the desert. We're not supposed to produce it at other times when we're well hydrated, but sometimes we do because of head injuries, for example, or also some other weird things. Some drugs can cause us to release ADH, can't they? Like thiazide diuretics, some antipsychiatric drugs, but also some lung things, some cancers, small cell cancer, bronchiectasis can, suppuration in the lungs, pleural effusions, a number of things. Brain causes, chest causes, and tablet causes can cause us to produce ADH wrongly. And what we do then is we hang on to our water when we should be getting rid of it, and we dilute our sodium. Yeah, is everyone okay about that's the mechanism? And of course, the problem with it, the danger is seizures, isn't it? But it's also can make people feel dreadful, weak, nauseated, and so on. But not always. You see people with quite low sodiums who don't even feel anything. They feel fine. Yeah. But so what do we do about with inappropriate ADH? So generally, the mainstay of treatment is fluid restriction, isn't it? The main treatment, but we sometimes intervene. And it's what's called severe symptomatic. So basically we look for, if the sodium is less than 125, I think, isn't it? And they're symptomatic. Sorry, I'm looking for the figure. I think it's 125. But if they've got symptoms, including seizures, for example, then we would use hypertonic saline. Yeah, and we'd give one dose, 150 mils of 3%. After 20 minutes, repeat it, and then get the results back. And you're looking for about a 5 millimole increase in sodium. And then after that, you go to fluid restriction instead. Okay, so it's that is the right answer. B. 31. 42-year-old man from Hong Kong collapsed while seated after a large meal. He was not aware of any warning. He recovered quite quickly. This is his ECG. What's the following is the most likely cause of his collapse? Yeah, it's pretty obvious, isn't it? So just to say a word or two about Brugada. So what is the Brugada sign or the Brugada changes on ECG? It's about this ST elevation and this odd-looking ST elevation in two of the V1 to V3 leads. So that's a Brugada sign. Is that enough to diagnose Brugada syndrome? So if you see that on an ECG, you pick up an ECG and you see that, is that enough to say, oh, you've got Brugada syndrome? You've also got to have either an arrhythmia or people in the family who've had who've got the same ECG, or people in the family who've had sudden cardiac deaths, etc. So you've got to have more than just the ECG, and you can actually have it tested in electrophysiology. They can provoke electrically to see if you go in, they can test it out somehow. Okay, 32. So this is a bruising question. Lots of bruises, and now he's bleeding a bit. Most likely explanation? he's quite well, so it can't be leukemia. These bruises aren't typical for Henoch-Schönlein. Henoch-Schönlein is copper-colored lesions. Viral-induced capillary fragility. What's that? Basically, if you have a viral illness, you can get petechiae in the upper body in children. Particularly if they're coughing a lot, they get petechiae just appear. So this is what this is getting at is ITP. Yeah. So ITP, they're usually perfectly well. Yeah, completely well children, a fairly wide age range up into the teens, right down to quite young children. And they just have a low platelet count. They're autoimmune digestion of the platelets. And the platelet count might be 6, 10, 12, really low. How if you find that, how is it managed normally? Platelet transfusion?
Steroids?
No, not if they're not bleeding. Basically, it's just watch and wait is the usual approach to it. No contact sports, wait, and then if they don't get better, immunoglobulin can work. Yeah, and there are other treatment options as well. UTI in children. So she's had abdominal pain, goes to the toilet often. Urine dip is positive for leukocytes, but negative for nitrite. Which is the right answer? Yeah, so we used to send these urines all for microscopy, didn't we? That was how we used to handle it, but then they changed the guidelines so that we should dipstick them and then make many of the judgments just on dipstick. And of course, I'm sure you're all familiar with this, that the two things that we test for are leukocyte esterase and nitrite. Nitrite, if you find nitrite, then there's definitely bacteria in the urine, definitely, because bacteria convert nitrate to nitrite, yeah. And it's definitely means a UTI. But or bugs anyway, leukocyte esterase, that's something produced by leukocytes. They could have come from anywhere. It's not necessarily a UTI. It could be from a vaginal source or from a kidney or something somewhere else. It's just a white cells got into the urine. So it's not as, it's more sensitive. It's a better way of picking up UTIs, but it's not as specific. Nitrite's very specific. You don't get false positives with nitrite. So they have this trade-off, sensitivity, specificity. Okay, and so if you get nitrites, you're home and dry. But if you get leukocytes, you're still not absolutely sure. And so if I just come to the, for over 3s who have leukocytes, you send it off for microscopy. So there's still this use for microscopy in the guidelines. For under 3s, you treat it. You assume it's UTI. But for over 3s, leukocyte only, you send it off, and then you judge on the result of the microscopy. Okay, so this is where it comes from. So in the NICE guidelines, they break it down into under 3s, which is a more aggressive approach to treatment, and over 3s. And so this is basically, what you do based on the result. What's the issue? Why do we bother about, why are we keen to pick up UTIs in children? Yeah, exactly. Yeah, good. Yeah, so it's all about picking up the people with abnormal structural systems, particularly reflux, because they may get long-term kidney damage and even go into kidney failure if it's not picked up. 34. Okay, 83-year-old man, general malaise, vomiting, constipation, tiredness and confusion. History of prostate cancer with bony metastases. And he's got a corrected calcium of 3.8. Single best initial treatment. Okay, everyone happy with that? Normal saline is the treatment. Yeah. So this is the Society for Endocrinology. This is their hypercalcemia guideline. And what do they say? Rehydrate with 4 to 6 liters over 24 hours. Watch out for overload, etc. We used to use diuretics as well, but it says don't do that unless you need to. And then after you've rehydrated, you then give them zoledronic acid or permidronate, one of these calcium binders. And then there are some second line agents like steroids at the bottom here. But basically, it's mostly about hydration. Main causes of hypercalcemia. The top 2, primary hyperparathyroidism, which is not that rare, and bony metastases, isn't it? Those are the top 2. And there's a series of other things as well, like milk alkali syndrome, which we don't see anymore, but vitamin D poisoning and yeah. 35. I think we've done this one, haven't we? Yeah, we've done this one already. Cortisol and ACTH, it's Addison's. 36. Sickle, 22-year-old man with known sickle, pain in the back and each upper arm. He says it's 7 out of 10. Yeah, it's morphine. Morphine. Okay, so we used to routinely give them oxygen and morphine and IV fluids. It turns out that the oxygen doesn't make much difference as long as they're reasonably well, as long as they've not got a sickle lung. And nor does the IV fluid help very much, but the analgesia does. So just quickly run over some other sickle complications in case they come up. So, of course, the commonest problem we get with sickle cell disease is painful crises, but there are a series of other things that can happen with sickle. What other complications do they get that might? They get this lung syndrome. Yeah, they can become hypoxic because of sickling within the lung. Yeah, so that's sickle lung. They get avascular necrosis of the hip. Yeah, they get strokes. They're vulnerable to a wide range of infections. Why? They lose the spleen. You get necrosis and shrinkage of the spleen eventually, and so they then become vulnerable to particularly to pneumococcus, pneumonia. They get infarcts in the bones, which get infected, yeah, and so they get osteomyelitis. And what's the unusual organism they sometimes? Salmonella in the bones, yeah, that's good. Great, I think that's they're vulnerable to priapism, it's another complication. They also get, if you get abdominal in a child with sickle, 6-year-old, say, abdominal pain and the HB's dropped. Yeah, acute splenic sequestration. One day, for whatever reason, the spleen decides, I'm tired of these funny red cells. Any that come through, I'm going to take them out of circulation. And so all the circulating red cells end up in the spleen, which enlarges and gets painful, and they become grossly anemic. And then the only other thing is, we've already touched on it, parvovirus, yeah, aplastic anemia. So there's a long list of sickle complications. Okay, so this is the sickle cell guideline. Okay, just about analgesia, importance of analgesia. 37, she's a netball player, caught a ball oddly, and this is her x-ray. What's wrong with her x-ray? Okay, everyone happy with that? Fracture base of the first metacarpal, often known as Bennett's fracture. Yeah. Significance of that is Why is it an important injury?
Is it not like a scaphoid?
No, it's not like scaphoid. It's because it displaces easily and you lose the congruity of your articular surface. And because you use your thumb a lot, you get arthritis early in your thumb. That's really, really problematic. So it's vital to restore the alignment. So it needs internal fixation, KY, something like that. That's the point for that one. Okay, I think we've done this subject fairly well now, so I won't spend time on it, but this is a osmolar gap question. You add the sodium, you double the sodium and you add the glucose and urea. So 260, 265, 275 is the calculated, but the measured is 310. So there's a 35 milliosmol difference. So there's an osmolar gap. So you're then looking for methanol or ethylene glycol. And it's most likely in the story, because of the story, it's most likely to be ethylene glycol. Of course, it could have been methanol, but the story is more like that. Okay, I think we might have done this one enough as well. Erythema infectiosum, 15 weeks pregnant. So the infective period is a week before the rash. So she's 15 weeks pregnant. She would have been vulnerable at that time, wouldn't she?
That's just the man.
So what does she need? Check her serology. Yeah, see if she's already immune. Because if not, she may be at risk. Okay, this is to do with the college guidelines on analgesia for children. Large burn to the right arm. Now, of course, you'd have to try and assess the level of pain, but you might assume that this is a 7 to 10, might you? Do you remember your pain ladder? Yeah, mild, moderate, and severe. Severe is 7 to 10. You might assume this is a 7 to 10. What are the treatment options for 7 to 10? Intravenous morphine, for example, would be an option. Short-term Entonox. But another quick method, if you haven't got IV access, is intranasal diamorphine. Yeah. (41). 58-year-old man, chest pain for 10 minutes, which is now settled. He's got this ECG. So he's got these broad T-wave inversions across the chest leads. And this is a bit of a classic. It's called Wellens syndrome, and it's caused by, it's not a STEMI, it's an N-STEMI, but it's serious, isn't it? It's got a particularly poor prognosis. Famously called the widowmaker, isn't it? You know, and it's quite a tight stenosis of the LAD, left anterior descending. Yeah. Okay, back to bites. Bitten by her dog, a puppy, 2 hours ago. Small superficial puncture wound. Oh, it is a puncture wound, so it has broken the skin. Oh, sorry, this isn't about antibiotics, this is about tetanus. Okay, so she should have completed her course within the last 10 years, shouldn't she?
Yeah.
So she needs nothing. Okay, another tetanus question, and then we'll look at I know we touched on this yesterday, we'll look at it a bit more again. 32-year-old man, nail in his foot, working in a building site, thin-soled shoes. Nail went into his foot and broke off. Anyway, he's come in, broken nail's been taken out now, and he completed full routine vaccinations as a child and adolescent, and he says, do I need a booster? Yeah. He requires a tetanus booster, yes. Let's just quickly just go through this. So I know we touched on this yesterday, but there's a couple of things to be aware of here. First of all, what are known as tetanus-prone wounds. What's tetanus-prone? So puncture-type injuries, foreign bodies, compound fractures, wounds or burns with sepsis, and certain animal bites. And the issue here is that actually it's only really animals that go in the soil, that grub about in the soil, that's an issue, because tetanus is a soil organism. So those are tetanus prone, and then you've got the high risk. This is the high risk list, heavy contamination, and this is where, you know, we talked about a guy who's put a fork in his foot yesterday, you know, which is what, but it's the classic agricultural injury. Somebody's got their foot in the lawnmower, you know, they've got a nasty soil contaminated wound. Devitalized tissue or delay. Those are high risk. So you then have the 3x3 table here. Clean, tetanus prone, high risk. And down this way, full course within the last 10 years, full course more than 10 years ago, and not full course. And so, you know, if you've got a full course here, you don't, if you had a full course within the last 10 years, you don't need any more tetanus cover in any of these categories. But if you had it more than 10 years ago, if it's high risk, you should have both vaccination, booster, and immunoglobulin in different arms. Yeah, they should be given in different arms, because otherwise the immunoglobulin will soak this up. Yeah, stop it working. Tetanus prone, you just give the vaccine. Is that okay? So that's the current. It did change a couple of years ago, but that's the current guideline. You then have a debate, is it tetanus prone or high risk? I think we've called it tetanus prone, haven't we? Yeah. Tetanus prone. So he's here. Yeah, more than 10 years ago. Yeah. If it was, you know, garden implement got in his foot with soil in it, then he'd be here. Is that right? You know, I know that sometimes you're going to be judging, oh, is it that one? Is it the other one? Yeah. 23-year-old, bloody diarrhea and abdo pain for 2 days. Before that, she had blood and mucus in the stools, slight temperature, tachycardia, blood pressure's okay, most likely. Yeah. Proctitis, yeah, yeah, presenting with blood, mucus, and pain. And finally, a liver function test. 60-year-old man is presented with painless jaundice. LFTs are as follows. So his bilirubin, of course, is high. That's why he's jaundice. His albumin is normal. Yeah. So he's not got chronic liver disease, or at least not bad chronic liver disease. His enzymes up a little bit. Yeah. Twice normal. His ALT. His alk phos is up more, isn't it? 3 times. So this is the sort of pattern for a obstructive jaundice. Yeah. So to get that much jaundice, but only quite, you know, with this sort of pattern, is an obstructive pattern. Hepatocellular, you'd have much, much higher enzymes. So obstructive pattern, 2 main causes of obstructive jaundice are gallstones, yeah, or carcinoma ahead of the pancreas. Yeah, those are the 2, aren't they? So the right answer is D. Okay, we finished actually slightly ahead of time. So we're all done. So if you, for those at home, if you haven't done your Survey Monkey, please could you do so? We are ahead of time, so if there's any questions anyone wants to ask at this stage, please do say. Okay, there's a question that's come in Q&A from paper 5. Yeah, can you just read it? Yeah. Yeah. So this is about intraosseous access, isn't it? I think you can. So it always gets difficult when people say things that I don't. So the question that's come through is, can you do a humeral head intraosseous access in a 3-year-old? I think you can, even though the child will have an epiphyseal plate. I still think you can put it into the epiphysis, into the head of the humerus. Yeah. So, but I you know, I'd be willing to be corrected, but I think you can.
I've just looked that up, Ian, and from about 7, it's easier. Before that, because of anatomy and palpating your landmarks, it's very difficult.
Is it? Okay.
Yeah, I didn't know that either.
But it's still possible, isn't it? Okay, all right, well, thank you for that. It's helpful just for everyone to have that information. Thank you for bringing it up. Was that Susan? Thank you, Susan. Direct and consensual, well, is this an RAPD question? Relative? Okay. Okay, so we're just quickly going to go, let's go over RAPD, relative afferent pupillary defect. It's worth understanding this because people do get confused over it. Okay, so we all know, don't we, if you shine a light into one eye, the pupil will constrict, won't it? But in fact, also, because of the Edinger-Westphal nucleus, you will also get constriction of the opposite eye pupil, yeah? So you shine a light in one eye, both pupils constrict. If your optic nerve is damaged and you shine the light in the bad eye, of course, you will not get constriction of either eye, yeah, because there's no signal, yeah. But if you shine a light in the other eye, the good eye, you'll get constriction of both, yeah. So if you shine a light in the good eye, you'll get constriction of the pupil on that side and also on the side that has the optic nerve damage, yeah, because it's the motor is parasympathetic. Edinger-Westphal comes through the third nerve. Yeah, yeah. Is that okay? So, but there's a bit more to it than this. So you can have a blind eye with a bad optic nerve, but still get pupil constriction if you shine light in the other side. Now then, when neurologists in the old days used torches, big torches, flashlights, they would go from eye to eye looking at the pupil reflex, yeah? So they shone the light in the good eye, both pupils constricted. Then they come across to the bad eye, and the bad eye's got a bad optic nerve, and so there's no signal going to the brain. Both pupils go back to normal. And it looks like it dilates. Are you with me? So this is what's called a relative afferent pupillary defect. If you go from eye to eye to eye to eye, the swinging flashlight as it's called, when you come to an eye with a bad optic nerve, it appears to dilate instead of constricting. It isn't really, it's just going back to normal from the small size. Yeah, that's an RAPD. Yeah, and it's classically a feature of multiple sclerosis because they get optic neuritis. Yeah, might also happen in a methanol poisoning there. It'd be bilateral. Yeah. Okay, should we call it a day at that? Let everyone go. Everyone wants to get home, don't they? Good. Thanks very much, everyone. I hope that's been stimulating, and do leave your evaluation forms if you're in the room with Karen before you go. And please, everyone at home, Karen will tell me in a minute how many have sent in there. 24 people sent in this. So if you haven't done it yet, please do send it, because we need a high, response rate to give us reliable answers. Okay, thanks everyone. CBD certificates will come out if they haven't gone out already. And you'll get online at home, you'll get the answer sheets for all of the 6 papers, and you'll also get the recording from today tomorrow. It will come out tomorrow. Everyone will get the recording if you want to go back over anything on the recording. Okay, so thanks very much, everyone. Let everyone go.
Thank you.
Thank you.
Thanks all. Cheers. Bye.
Thank you.
Thank you.
Cheers. Thank you.